Hello everyone, this is Dr. Andrew Heyman once again. We will be addressing Triad 3 today in our continued discussion of a systems biology approach within the context of integrative medicine. We've already reviewed Triad 1, adrenal, thyroid, pancreas, which is the set of hormonal relationships which are reflected in our exposure to issues related to stress, nutrition, energy production. And when this triad is imbalanced, we know that people tend to gain weight and they're tired. It's a major doorway through which people begin to create imbalances in their physiology. The second triad, which we recently covered in the last 2 weeks, has to do with gut, immune, brain. We spent some time looking at the relationship between the digestive tract, the immune system, and the central nervous system, and how those three bodily systems stand in permanent crosstalk. We know that when there are disturbances in one, there typically are disturbances in all three, and they progress from functional to biological in that regard. It's more complicated than Triad 1, both in terms of the underlying physiology as well as the disease expressions that arise out of Triad 2. It also means that our treatment options are broader as well. I would also argue that from an integrative perspective, we have a lot to say in terms of rebalancing patients that typically express symptoms such as chronic fatigue, fibromyalgia, depression, anxiety, irritable bowel, where we don't really have good treatment options within the conventional toolkit. But when you look at how we evaluate these individuals and the potential therapies that we can apply, you can make a lot of progress in those individuals that resonate along the lines of a Triad 2 imbalance. Triad 3 is similar to Triad 2 in that we're looking at whole body systems, and in fact it contains the number one chronic illness in our country, which is cardiac disease. This triad in particular looks at the relationship between the brain and the heart as mediated through the autonomic nervous system, the respiratory response, and the ways in which heart disease evolves sometimes in tandem with brain-related issues. So we know there's an overlap, for example, between cognitive decline and heart disease. And I think it gets back to that notion of as the heart goes, so does the brain. And that when we're looking to protect against end organ damage, we are basically dealing with the same set of strategies. I like Triad 3 because it often represents an accumulated set of metabolic imbalances that are expressed through Triad 1 and Triad 2, meaning that as you create pressure on the first two triads, we often begin to see imbalances in Triad 3 as well. And in speaking with my cardiology colleagues, that's exactly what we typically see. In fact, they spend a lot of time in terms of a patient that might have high cholesterol or high blood pressure or even known heart disease, really working on Triad 1 and Triad 2. So correcting the diet, decreasing inflammation with maybe some food sensitivity testing, modulating the stress response, and ensuring that there's balance within the first two triads. We often tend to see a resolution within the domain of Triad 3 when we're successful in restoring Triad 1 and Triad 2. With that being said, there's a whole set of specific treatment strategies that you can apply to Triad 3. And they can be very, very helpful for these patients where, in fact, you may have to deal across all three triads. This is what we call stacking. This notion that, yes, people can have imbalances within a triad, but of course, life is more complicated than that, and you can have imbalances that stack or impinge from one triad to the next. So we know, and we talked about this, how stress impacts Triad 2. And it's quite clear, of course, that stress also impacts Triad 3. So today we'll be reviewing that set of relationships that's defined by Cardiopulmonary Neurovascular, which contains the vascular tree, the autonomic nervous system, as well as components of the central nervous system, and then the cardiopulmonary circuit. So cardiopulmonary neurovascular. The core of this triad is about circulating of nourishment, oxygen, nutrients, removal of waste within the bloodstream, and the role that the lungs play in particular in terms of releasing some of those byproducts. It's the heart-brain-lung connection, three large organ systems that all stand in crosstalk, in the same way that the gut, the immune system, and the nervous system also stand in crosstalk. In some ways, it is a great recognition of the traditional healing systems that understood that breathing and breath links the mind and spirit, the heart and brain, and that when we calm the breath, when we focus on the breath, we begin to see a resynchronization between the heart and the brain. And this happens on a functional level, it happens on a physiologic level. There's a tremendous amount of research in that regard. And we also know that there's a great amount of overlap between heart disease and central nervous system problems. That, in fact, there's a correlation between cardiovascular illnesses and cognitive decline and depression in particular. And it reflects the same kind of interlinking that we see between gut, immune, brain. And this is also an expression of the heart, brain, lung set of relationships as well. Because of that, in some ways, I place it as the heart of the triads. And it's because of that notion that when we have imbalances in Triad 1 and Triad 2, we tend to see expression of those imbalances in Triad 3. Vascular-related inflammation and injury, which tends to predate cardiovascular disease, and the same is true for the cognitive-related issues. When it's normal, there's strength of spirit. It's that sense of having plenty of competency in the world to get things done. So we talk about the heart of a lion, in a sense. And I think in a more global context, it's about the individual's spirit as it applies to one's performance in the world. So strength of mind, strength of heart. But when it's imbalanced, we see inflammation and spasm. And what's interesting about this is that inflammation can occur on subtle levels. So we know that there is vascular-related inflammation, there is brain-related inflammation that represents the earliest metabolic disturbances within these physiologic systems, and that if left unchecked and progresses over periods of time, these functional alterations begin to accumulate in more physical alterations. And so we begin to develop plaque in the arteries, which tends to predate frank cardiovascular disease. We also know there's a component of heart disease that is not structural, that in fact, of course, 50% of individuals who sustain a heart attack don't have real noticeable buildup of plaque along the arteries. But we know the core of heart disease really is inflammation. That's been stated for many, many years. What's growing is our commensurate understanding of brain-related inflammation and the plaquing that we see essentially in the brain as a result of inflammation related to Alzheimer's disease and even Parkinson's, as well as additional neurocognitive disorders. Inflammation, we now think, stands at the core of mood disorders like depression and anxiety as well. What is specific, I think, to this particular triad, though, is that the inflammation occurs not just on the metabolic level, but it also happens on a more sort of global observable level, that the inflammation and spasm that we see relates to also sort of how people operate in the world, as well as the expression of the organs. So the sort of spasm and throes of a heart attack, the spasm of arrhythmia, the inflammation and sort of drama of a stroke, in a sense. These are very obvious events. And if you think about it, this is the triad where the ambulances show up. The lights are on. It is a critical moment where, tissue and oxygen is health. And we talk about having to get patients to the ER as quickly as possible to restore blood flow to the brain or blood flow to the heart tissue. And by contrast, if you think about gut, immune, brain, that's a slow and quiet death. That those illnesses tend to eat people up inside. It's the irritable bowel, it's the autoimmune disease, it's the cancer, it's the neurocognitive issues. Those are not the illnesses where ambulances tend to arrive at one's doorstep. when people have a major stroke or heart attack, when there's a dramatic decline in a patient's health status, this is the triad that tends to be invoked. So I always think in terms of where is the energy going in an individual, physiologically, functionally, as well as even spiritually. And so I often think of gut immune brain as an energy that's going inward. It's devolving the individual in a sense. And cardiopulmonary neurovascular, on average, is an energy that tends to go outward, that when this triad becomes imbalanced, it can become relatively obvious over time. And certainly, yes, there are some things that don't fall into that model in terms of, the silent disease of hypertension. But on average, this is a triad that tends to expand to become spasmodic and pretty obvious when it's disrupted, as opposed to Triad 2, where, you wake up one day and unfortunately it might be an individual who has metastatic cancer. And so, there are these elements of characteristics to these triads that I always like to think about and apply kind of almost a personality to them. And that's important for me as a diagnostician, because I'm always looking for and listening to, well, where is the direction of energy? And you can even sort of apply it from a public health perspective. And if you think about, demographics of illnesses related even to gender, irritable bowel, depression, autoimmune diseases, we know women tend to have more of those. And the same is true for cardiopulmonary neurovascular, arrhythmias, heart disease, strokes. Men tend to have more of those as well. And as a personality, in a sense, that yin and yang, the sort of the quiet, grounded, centeredness of that female energy is sort of the strength of Triad 2, and by contrast, that sort of male energy of being out in the world, being productive, being strong in oneself, and getting things done tends to be categorized more as that yang. And certainly, it's not meant to be sort of a hard and fast, and it's certainly not even meant to be sort of gender specific per se. Because, of course, men can have more of a yin energy, women can have more of a yang energy, but it's sort of that notion of patterning. Where do these things arise in the physiology? Who has them as an individual? Who is vulnerable to developing these imbalances, in a sense? And so I'm always thinking about these things in the context of my patients and trying to better understand, well, how did they get to this place initially? And what can I do to sort of better balance them as an individual? We can start with a physiologic model. It's sort of that ground matrix of nutrition and stress and herbs and supplements. But over time, I think practitioners, if they're interested, they can begin to really layer in some of the other more gentle balancing techniques of homeopathy, acupuncture, energy work, breathing techniques, that operate at that kind of higher vibrational state, in a sense. And so, that's the challenge and the privilege of an integrative provider. There's always more to learn. There's always more to integrate, if I can use that term. But the triads form the basis of the systems biology model. And their value, I think, is in that they tend to begin to explain patterns. And those patterns are also reflected in the vernacular and viewpoint of traditional healing systems. So we're trying to begin to bridge the gap between observation and measurement, in a sense. And certainly the observation of that spasm and inflammation, the drama of a impaired Triad 3, I think is pretty characteristic for these individuals. So geosynchrony, meaning that we are in sync with the change in seasons and in sync with our environment. It reflects that same notion of Triad 1 with the rhythms of cortisol and insulin and thyroid. Coherence is a very specific term. It comes out of the heart rate variability literature, which is the neurologic linking of the brain and the heart, and that when those two are operating in a state of coherence, we have health between the two. We have positive information flow up and down the chain between the heart and the brain. I think the energy here, as I mentioned, is sort of expansive and energetic. It's out in the world in a sense. It's not necessarily quiet. It's one that's pretty obvious in its industry. And so, on a more global level, when we have plenty of Triad 3 energy behind us, I think we are effective. We can be industrious. We're resolute. And that's that sort of warrior monk that I'm ready to do battle. I'm ready to, defend what I need to defend, to, be who I need to be in the world and not apologize for that. But also have a sense of spirituality about it that, we have a purpose and meaning in our lives that links to that notion of being an actor in the world in a sense. But it is an energy that's generated, but this is an energy that can run out of control. It can run over people. It can be quite dangerous in a sense. You could argue, for example, the emotion anger is one that stands at the center of this triad, but not in a bad way. One can leverage that emotion and similar emotions to get things done, to be resolute and forthright in the world, but it can also be incredibly destructive. And so, we need to temper that and sedate it and contain it and focus it for the benefit of ourselves and our family and people that we care about and sort of projects and purposes in our lives that we care about. But this also can run out of control. And when it runs out of control, we tend to have inflammation and spasm. So I think this is a very interesting triad, and one that I've certainly personally spent a lot of time on with regard to having done a lot of research in the area of heart disease and alternative therapies over many years at University of Michigan. And so, while in some sense it's obvious in its disease state, it's not always obvious in its healthy state. And so we'll focus on that with a treatment of the Triad 3 topic. So cardiopulmonary neurovascular, we start with the vascular tree in our modeling of this triad. We then get into the neurologic components and how they integrate with the vascular system. And then when those two become imbalanced, we begin to see expression of cardiac illness. And so that's the kind of progressive model that I'll be describing within this particular lecture. On a more biological level, we have the single endothelial lining of the vascular system. If you think about it, it's the second major interface in the body, and it really models gut-immune brain. So you have a tube, essentially, that is the epithelial lining. It is a single cell layer thick that protects us from the outside world. And then just standing on the other side is the immune system and the nervous system. The same is true for the vascular system. It's a single cell layer thick, composed of tight junctions. There's transmigration of products from blood tissue that move across this lining and interfaces with the immune system, the muscular cells, as well as the nervous system. And so it functions very much like a smaller version, in a sense, of the gut-immune brain. And so when you think of it from that perspective, it turns out that there's leaky vessel syndrome. And as much as you can have overriding of the tight junctions and develop leaky gut, you can have this leaky vessel, which leads to chronic inflammation both locally in the vascular lining, but is also a predisposing factor for end organ damage with the heart and even the brain. It is the architecture of circulation itself, as I've mentioned. It does reflect gut-immune brain in a global sense, and it's another one of our major biological interfaces. The third, just to sort of complete the picture in a sense, is the single endothelial lining with tight junctions of the blood-brain barrier. And we can have threats to our physiology that override that gut, vascular, and ultimately blood-brain protective layer. When that occurs, we see major end organ damage. So the heart becomes inflamed, the brain becomes inflamed, and so there's a symmetry in the way that the body is organized. It's beautiful in its arrangement, and it's very logical in that sense. And so when you begin thinking about it in those terms, I think things really begin to open up for you as a context of, from a systems biology perspective, how are we organized? In terms of the neurologic, we have the balance between the sympathetic and the parasympathetic. This is the relationship between the autonomic nervous system, the autonomic sides of the nervous system. It's the active side and the rest and repair side. And there has to be tone in both. But when one overrides the other, and sometimes in a chronic sense, this can lead to not only sensations that might be unpleasant for the individual, but also physiologic changes that tend to underpin a variety of health-related problems. We also have the participation of the central nervous system, the amygdala, the prefrontal cortex, the hypothalamus, all of which are control centers for the autonomic nervous system in a sense, or reflect feeling states as well as kind of basic nerve-related activities in the periphery. And so this is what begins to link the mind and the heart. So when we have balance, especially in the autonomic nervous system, the heart and brain can communicate effectively with each other through these electrophysiologic flows of information that go up and down the chain. One of the things that majorly regulates the balance is breathing and breath work, calming the mind, calming the breath, focusing on the respiration. For thousands of years, this is the basis of awareness, of contemplative-based practices. This notion of the first thing we do as we enter the world is we breathe. It's the cry of life, and we take our first inhale. And if you think about it, inspiration is to breathe in spirit. It's the first life-affirming activity of who we are as individuals as we enter our earthly realm, in a sense. And so all of the traditional healing systems have a notion of breath, of connecting to it, slowing it, pulling breath in, bringing it to our physical and spiritual center. And what they didn't understand, though, is that what they were doing is resetting the relationship between the sympathetic and parasympathetic nervous system. It's beautiful in its arrangement as well. And breathing is something that we often forget about in terms of talking with our patients. It's incredibly powerful. It takes practice, though, and it's a discipline that will have benefit over time with your patients, but you essentially have to retrain their breathing patterns to be able to move easily into that calm state. And so the breath, which is the link, I think is incredibly important in the context of Triad 3. And then finally, the kind of end organ issue, the heart as a pump. And in addition to these notions of the links, the respiratory sinus arrhythmia, as well as heart rate variability, which is the kind of neurologic characterization of the relationship between the heart and brain, but also, of course, the heart being a central driver of physiology. So sort of buried in Triad 3, we have brain. It's there as a relationship with Triad 2. But it also stands in relationship with Triad 3 as it relates to heart function as well. So we, again, have that stacking effect that occurs between Triad 1, Triad 2, and Triad 3. So we'll begin with pathologic disturbances. And the earliest would be within the vascular system. We know that there are the twin flames of oxidative stress and inflammation. Oxidation is very simply overexpression of reactive oxygen species, which can lead to rusting of the cell membrane as well as organelles within the cells. And an overexpression of oxidative stress tends to signal, among other things, a devolving of enzyme activity within the vascular system. We have new markers for oxidative stress. One is 8-hydroxydeoxyguanosine. This has become a very reliable marker of DNA damage due to oxidative stress. You can also measure pH status as the body becomes more acidic. There's generally more oxidative stress as a result. I talked about this in gut immune brain. It's also clearly important for Triad 3 as well. I think we've focused on inflammation quite a bit already. We know that insulin can drive inflammation, stress can drive inflammation. It clearly stands at the core of gut immune brain, but it also occurs within the vascular system too. And so when the endothelial lining is becoming inflamed, whether it's because of localized insults along that cell layer or more systemically because the body overall is inflamed, we can see damage to the vascular tree. It's the sort of initiating step. So you'll see a lot of treatments designed to either reduce oxidative stress, like green tea extracts, or reduce inflammation, like curcumin, for example, or fish oils, all of which is designed to try and protect the vascular system. The blood tissue itself also participates in the role of vascular disease. We can end up with hypercoagulability states, usually from inflammation. There's sometimes a contribution of genetics as well. So the blood becomes sticky. We see elevated levels of fibrinogen, D-dimer, PI1, and all of this is signaling that the blood tissue is not flowing as properly as possible. And so we want to have strategies to both measure as well as treat if the blood is becoming too sticky. It's a signal, in a sense, that the vascular system is becoming compromised. The blood is sluggish. It's not moving appropriately through the vascular tree. It will be caught up in the capillaries and create risk for thrombus formation, or more colloquially, a clot. In addition to that, we've, of course, in the cardiology literature, focused on dyslipidemias, abnormal cholesterol levels. And at the core of this is the relationship between oxidation and cholesterol. That oxidized LDL, rusting of LDL particles in particular, might be the greatest risk factor that we've been able to identify with regard to the initiation of cardiovascular disease. So you can both measure 8-hydroxydeoxyguanosine as a global assessment of oxidative stress as it relates to DNA, but you can also measure oxidized LDL, and we think this might be the most predictive. Interestingly, there is some argument that, in fact, cortisol levels might be the most predictive of heart disease, especially hair samples of cortisol. You would think of hair samples of cortisol as a hemoglobin A1C of stress, that cortisol is expressed in hair, and when you do an analysis, it reflects about 3 months' worth of total cortisol output. And the higher the cortisol levels, the greater the risk for heart disease. And so whether you're looking at oxidized LDL, hair cortisol samples, states of inflammation, hypercoagulability, these are all pressures or forces that begin to accumulate with respect to creating potential damage to the endothelial lining. So if the endothelial cells are oxidized, if we're oxidizing LDL, it makes LDL more pathological and more readily able to deposit itself along the vascular lining. It will establish a certain level of inflammation as a result. The blood senses this and becomes sticky or hypercoagulable. So all of these pieces sort of fit together as a composite picture of, what's going on with respect to the functional changes that predate more structural abnormalities within the vascular system. So plaquing of the arteries, once again, is only one measure of that. We know that as arteries become stiffened and less compliant as a result of these forces and factors, that's where we see greater or enhanced risk. And so as well as a result of that stiffening, there are additional responses. So for example, we have prehypertension or hypertension, and that is the blood pressure starts to go up because of stiffening of the arteries, in a sense. This could be age-related, but it's also due to the aforementioned risk factors. In addition, and finally, there's excess permeability. That, in fact, the blood vessels become leaky. And we can even measure microalbumin in the urine as a potential indicator that the tight junctions are beginning to break down, and proteins are starting to transmigrate across the lumen of the vascular system. So this is a model of atherosclerosis over time. This is sort of the traditional model in the sense that we have a progression from what's called endothelial dysfunction. This is not necessarily a new concept, but it's gaining a lot of attention. It's this notion that it's the function of the endothelial cells that is so important as an assessment of the overall health of the vascular system, meaning do these endothelial cells relax appropriately? Can they accommodate the impulse of blood as it traverses the vascular system? Or do we see an inability of these endothelial cells to be compliant and relaxed and soft? And as they stiffen and thicken over time, this is what tends to predate or signal that we have the development of vascular disease. There are a variety of tools now that you can use in your practice to directly assess the compliance of the endothelial lining and whether or not it relaxes appropriately. In some ways, this forms the basis of all the Nobel Prize work that was done on nitric oxide. Essentially, it's a gas that's released in the vascular lining, and it's the signal for the blood cells or the vascular cells to relax. When that happens and we have good pliability and compliance, we have normal blood pressure. And as those cells start to lose their competency, they reduce in their ability to produce nitric oxide. This is sort of the initiating factor and signal that that these forces of inflammation and oxidative stress are beginning to load or build in the vascular system. And so we keep looking for more and more subtle signs of what predates frank measurable flow problems, that it's not just a plumbing issue of thickening of the arteries. That's sort of the last step in a sense, but we want to also be able to better characterize those risk factors that are accumulating within Triad 3 that will start impinging on vascular health. And so we know this kind of occurs over time related to age, but this also reflects greater and greater forces that we do to ourselves in terms of stress and poor diet and toxins and exposures and infections and so on and so forth that begin to impinge on vascular compliance. The older model, in a sense, is that you could see towards the right, a plaque forms, which is a fatty set of deposits with a cap, and ultimately this cap ruptures either due to excess forces because of high blood pressure or an initiating or insulting event. And when this cap ruptures, we have a thrombus that accumulates on top, and then blood flow is stopped within this artery. Coronary artery disease then is blockages that accumulate in the arteries around the heart, but we can have peripheral vascular disease, so these are blockages in the periphery of the body, as well as cerebrovascular disease. These would be thrombuses that form in the arteries that go to the brain or within the brain itself. And all of these can be critical situations where if you have a major artery that becomes compromised and has poor blood flow, the tissue that's fed by this artery begins to die, and so time is tissue. This is why the ambulances show up, because we want to restore blood flow quickly to those end organs. But we also know at least 50% of patients that develop these sort of events, they don't have significantly visible or thickened arteries or vascular plaquing. That there's all these sort of metabolic issues that are really occurring in most of these patients where a thrombus can form, but not necessarily because of this cap rupture in a sense. But these other forces that we're beginning to identify are just as pathological, and we want to be able to manage them. Either way, when the patient gets into this state, it becomes a critical emergency, and we need to restore blood flow. And so that's where stenting and balloons and TPA and so on and so forth begin to play an important role in ER cardiovascular centers. But our job as integrated providers is to identify when these forces are accumulating in our patients within Triad 3 long before a compromising event like that happens, because you certainly don't want them to have a heart attack or a stroke and damage those organs. So what are the traditional set of cardiovascular risk factors that I think we've all been trained in? Smoking, diabetes, hypertension. Those are the big ones. I would also say high cholesterol, obesity. These are the ones that we typically care about when we're doing our normal primary care. We want people to be of normal weight. We want to assess for whether or not they have high cholesterol, high blood pressure. Are they developing insulin resistance or diabetes? And do they have a smoking risk or strong family history? That's sort of the intellectual set that most of us who are trained in primary care go through. But within that mix, there's shear stress, which is, of course, the forces that can occur across the blood vessel, usually to stiffening or thickening of the arteries themselves. There's oxidative stress, and I would add inflammation too, although in this model, they say that all of this loads into inflammation, which I guess I would agree with. And then finally, there's always been this question of infection. Are there bacterial loads in particular that we can find in plaques of the arteries that might also predispose an acceleration towards heart disease. But if you look on the left, we know that these factors are some of the forces that begin to create endothelial dysfunction, meaning that we're beginning to compromise those healthy cells that line the vessel, and they should be able to easily generate nitric oxide. When they don't, when they're not able to produce that, when we see a decline in nitric oxide production, we have a real impairment in the cell's ability to relax and perform normally. And we see an overexpression of endothelin, PDGF, as well as ACE. These are enzymes essentially that begin to create hypercoagulability in the blood, localized inflammation, spasticity of the arteries. And so a number of our drugs, for example, are targeted at things like ACE. So we have ACE inhibitors, which are designed to decrease blood pressure by blocking this enzyme. What happens as a result of these vascular mediated changes is we have an expression of an inflammatory marker, which is incredibly important, called NF-kappa B. NF-kappa B signals inflammation along the vascular lining as well as systemically. One of our tools that's very good at blocking NF-kappa B is actually boswellia. So we don't hear a lot about boswellia in sort of even natural treatments for heart disease, but it's really, really good in that regard. This inflammation then that's arising out of these metabolic changes along the endothelial lining can lead to overexpression of adhesion molecules like ICAM and VCAM. So again, the blood becomes sticky. It means that platelets and other blood factors will bind to the endothelial lining and begin to aggregate. We have chemotactic proteins, which are calling in inflammatory proteins, the interleukins like IL-6 and IL-1B, which also are the initiators of the systemic inflammatory response, C-reactive protein, and in particular high sensitivity C-reactive protein, which both is a signal of inflammation in the vascular system, but it's also injurious itself to the vascular lining. And so, yes, we can measure high sensitivity C. We also want to reduce it because we want to reduce the risk that comes from it. As a result of all of these shifts from a normal endothelium to one that's inflamed and expressing these potent signaling molecules, we begin to see the blood change itself. So increased platelet aggregation, fibrin deposition, because we've activated the complement pathway, as well as the clotting cascade, and then finally plaque growth as a result. So we have overaccumulation of fatty deposits due to activation of foam cells within the vascular lining. It starts to thicken, it forms the fibrous cap, and ultimately what can happen as a result of all of this is plaque rupture. So we have an acute event in a sense. So this is the traditional model, and this provides areas of intervention for all of us in terms of risk factor reduction. We want to address Triad 1 with respect to managing insulin resistance and stress. We also want to measure and modulate Triad 2 because we know that the gut is a major engine for systemic inflammation, as well as just dealing with systemic inflammation, which we know can help with protecting the blood vessels. So it's sort of that gut-heart relationship as much as there's a gut-brain relationship or heart-brain relationship. And what we're trying to do is prevent the major event. So Triad 2 has the dwindles in the sense of, if we have overactivation of the immune system, we're at risk for autoimmune diseases and cancers and immune dysfunction. Triad 3 will load all of that into the vascular tree, and we have more structural related issues with the vascular lining, stiffness of the endothelium, which can lead to plaquing as well as gross hypertension, which puts both the brain and heart at risk. So this is a model of the vascular system, and if you look at it long enough, you'll say, well, this looks like the gut. Single cell lining, you can see the endothelial cells attached by tight junctions. There's the basement membrane, as well as the intima and the media, which stands right on the other side. Those are smooth muscle cells that have accumulated along the lining. But when we have transmigration or overriding of those tight junctions by chemokines and immune compounds, they begin to encounter macrophages that will be signaled as a result of the migration of these factors. And so then they're translated into foam cells, which then begin to express all sorts of inflammatory markers, as well as reactive oxygen species. So we have excess oxidative stress and inflammation with production of cytokines. And so this is what initiates smooth muscle cell migration into that area. The body's trying to protect itself against the inflammatory response and really injury that's occurring. And the same is happening on within the tissue of the blood. So if the blood is becoming more oxidized, we have oxidized LDL. And this is what creates pathological LDL in a sense. So there can be a genetic predisposition. There's a variety of gene markers that you can draw now. The 9p21, which is one of the risk factors for vascular disease. There's KIP6, which is supposed to help us choose between statins, as well as our traditional risk factors, which I mentioned. There is this growing notion of maybe infections in the mouth or other body compartments might also predispose to vascular disease. But the end expression is overproduction of inflammatory proteins, as well as reactive oxygen species. And this creates both functional as well as structural changes within the vascular system, and ultimately can predispose to thrombogenesis, whether that's a functional plaque or a structural plaque. So we have to be able to assess for, are we oxidized? Are we inflamed? Are there changes in blood vessel compliance? Are we losing endothelial function in a sense? And where can we intervene to decrease these forces that are impinging on the vascular tree? Again, a lot of this can be silent. So it could just be someone who's a smoker, who's under some stress, they're not eating as well as they should, and they don't realize that they're actually accumulating endothelial function in their blood vessels. So it's hard sometimes to identify these people unless you do some measurements. You need to do, your expanded cholesterol profile, check their blood pressure, check for inflammatory markers in the vascular system, like high sensitivity CRP, and see where they're at. Sometimes this is progressing, and it's hard to know unless you actually get some blood values. So here we have your traditional set: hyperlipidemia, hypertension, diabetes, cigarette smoking, and myocardial issues, insulin resistance, essentially. So all of which can lead to a dysregulation of the core feature or function of the endothelial lining, which is nitric oxide production. You can see that on the right bubble. And so there's an enzyme called eNOS, which is responsible for cycling arginine, an amino acid, to citrulline. And it turns out that this can be impaired as a result of all of these forces. So one of the clinical strategies that you'll often see from the natural toolkit is replacing arginine. It turns out that you also need high amounts of citrulline. And the rule of thumb is if the patient is 45 or 50, that's the cutoff for knowing when to do one versus the other. If they're below 50 or so, arginine tends to work better for lowering blood pressure. If they're above 50, we think citrulline might be the better option. Quite frankly, a lot of people are doing both. Arginine you can get as a single amino acid. Citrulline tends to come from beetroot. And so you can see a lot of products now that are hitting the market where they're beetroot derived citrulline supplements. And so if the patient has progressed hypertension, you may want to consider beetroot in addition to arginine. But what you're trying to do is improve the cell's ability to make nitric oxide, which is the signal to relax. It's the signal to decrease inflammation, and it's the signal for the blood vessel to remain healthy and active and pliable. When we have decreased production of nitric oxide, as a result, there's a variety of issues that arise, which includes, as you can see, the platelet aggregation, the inflammation in the blood tissue, the calling in of oxidized LDL attaching to the vascular lining. And so we have a variety of activities that occur that begin to accumulate over time that can lead to heart disease. But the initiating event, we think, sort of the final common pathway of all of these risk factors is a decrease in nitric oxide production. So this notion that oxidative stress And I would say inflammation with expression of NF-kappa B is what can lead to endothelial dysfunction. So we see a diminishment of nitric oxide. We also see an increase in superoxide radicals. And so this in turn can lead to a whole set of changes in the vascular lining, including overexpression of high sensitivity CRP, lipid peroxidation, so again, rusting of lipids in a sense, or cholesterol. Platelets become sticky and begin to aggregate along the blood lining. Vasoconstriction, so blood vessels are much less compliant. They like to squeeze as opposed to relax. And then proliferation of smooth muscle cells. So within the intima and media, we see a migration of smooth muscle cells right up against that basement membrane. And so there's a physical structural thickening of the arteries that's sitting actually below the thickening that occurs with the fatty deposits that are accruing within the vascular lining. So this kind of composition of fats and cholesterol sitting on a thickened smooth muscle cell pile with the fibrous cap on top, that's sort of the architecture of a atheroma. And so when the work had been done on nitric oxide, this gas that essentially is produced within the vascular lining was performed. It really was a revelation. We didn't know that there was this temporary, very brief production of nitric oxide, which was so important for health in a variety of body tissues, not just the heart itself, but the liver, the lungs, the brain. It even is important for immune defense as well as gastric mucosal protection. And again, when it's in balance, we see normal levels of pH. And as pH levels drop, the body's becoming more acidic and oxidized. We have less vascular ability to produce nitric oxide. This is a very messy slide. I put this in here just to show that, in fact, here's your eNOS that stands just left to center. And there's a variety of genetic activity and transcriptome activity with mRNA, especially with hypoxia-inducible factor and PIP3K, which are important for eNOS activity. And when we have overexpression of hypoxia-inducible factor and chronic inflammation as a result, we see VEGF as well as TGF-beta1 begin to accumulate. These are both hormones as well as inflammatory markers that impinge on eNOS. And when eNOS begins to decline in its activity, we can't produce nitric oxide from arginine. And instead, you'll have an overaccumulation of ADMA. ADMA is particularly injurious to the kidneys. What's not on here, which I would put in, is citrulline. And so arginine and citrulline actually work in tandem to help the body produce nitric oxide. When we have shunting away from eNOS, we have overproduction of these superoxide anions, which lead to vasoconstriction and leukocyte adhesion, platelet aggregation, and cell proliferation. You can also see as the endothelium produces more of ACE, which is the ACE inhibitor, angiotensin converting enzyme, you can have overexpression of angiotensin II and angiotensinogen, and those become targets of our blood pressure medications. We really want to block down on the right side of the model and begin to support conversion of arginine into nitric oxide. And this requires sort of a multimodal approach. Again, the end result of endothelial dysfunction is really anywhere blood vessels flow. And so it can be the brain with stroke and dementia and memory loss, vision loss, heart attacks, heart failure, and angina. Erectile dysfunction in the men's health literature, when you have poor blood flow to the penis and the result in erectile dysfunction, we think this is one of really the most predictive risk factors for heart disease, at least in men. So whether there's vascular compromise in the central vascular system or peripheral vascular system, we take that seriously. And if you have a male who is expressing problems with erectile dysfunction, and if it's a blood flow issue, if it's essentially a plumbing issue, if you want to call it that, then they're at much greater risk for heart disease, and that needs to be addressed. Peripheral vascular disease, so these are patients that have pain or discomfort for walking even short distances. For women who have known cardiovascular disease, they're at risk for preeclampsia. Certainly poor blood flow to the kidneys, renal failure. I know that we don't spend a lot of time, even in the integrative community, looking at kidney function, but as part of the drainage organ set of liver and lymph, we really need to restore normal kidney function. And as a major filtration unit, we put them in Triad 4, which is drainage. And that is to say, how do we help the body rid itself of exposures and ensure that there's adequate ongoing detoxification? When you have renal impairment, not only is there a risk for toxicity of all sorts, but also there's a direct relationship between the kidneys and cardiovascular disease. Diabetes, a Triad 1 phenomenon. Raynaud's, which is really more of a central nervous system issue. Yes, it's spasm of the blood vessels, but usually that's due to brain-related changes. Hypertension, obviously a known risk factor. And then sleep apnea, which is a risk due to usually obesity. There can be genetic reasons or structural reasons. But in fact, sleep apnea has been linked in particular to pulmonary hypertension. So you want to make sure that your patients are sleeping adequately at night. I send my patients all the time for sleep studies, usually when their BMI is approaching 30 or higher, especially if they're a known snorer or they have these apneic episodes observed by a bed partner. So in this particular model, I put this in because I just wanted to show the recycling of citrulline and arginine. You need both essentially to produce nitric oxide. There are some companies on the market that claim that you can measure nitric oxide with a tongue dab. I don't know how accurate that is. I've looked at some of the science. I'm not sure that it's really representative of what's going on in the endothelial lining. Maybe with a little further investigation, you might find that measuring nitric oxide with these test strips, these tongue test strips, are effective. I'm just not sure yet. But of course, it leads to a product sale with regard to wanting to promote beetroot extracts, which are high in citrulline. But usually, if they're hypertensive, and over the age of 50, you may want to just consider replacing citrulline pools in addition to arginine. And so this is a model of how there's the interrelationship between oxidative stress and inflammation. So we can see that when you have increased activity of NADPH, this, which is stimulated through angiotensin 2, as well as just general oxidative stress in the body, we have the overproduction of reactive oxygen species. This in turn tells the vascular tree and the liver in particular to produce NF-kappa B. Remember, Boswellia helps to block NF-kappa B. But when that occurs, we have overexpression of IL-6 and TNF-alpha. And so this is that kind of circular relationship between when the body's inflamed, it tends to be under oxidative stress. So you want to block down on oxidation as well as decrease inflammation. You don't want to overblock those two issues, but you want to have a normal high sensitivity CRP. You want to have a urine morning pH that's essentially above 6.5, if not 6.8. The patient needs to have slept or rested at least 6 hours before you do that. You can also, again, get that 8-hydroxydeoxyguanosine. So we have some relatively reliable markers for looking at the relationship at a measurable level, and we can infer that if they're normal, there's generally little pathological activity. If they're abnormal, if they have high levels of inflammation, high levels of oxidative stress, and they're hypertensive or prehypertensive, if they're hyperlipidemic, if they're a smoker or they have insulin resistance, you do worry that they're at risk for the development of heart disease as well as cerebrovascular disease. And all of this, again, is to say that it can load into endothelial dysfunction. And I'm repeating this over and over because this really is the current thinking, is that if the blood vessels can't relax, if they can't produce nitric oxide adequately, this is the initiating factor. And so we just want to make sure that all of the forces that surround the blood vessel from the outside in are managed appropriately. And this is why I think the cardiologists who really like the Triad model focus on Triad 1 and 2, because they tend to really capture many of the driving factors for what can lead to cardiovascular disease as an end expression, in a sense of where these patients can go. And I often think of it that way, that there's these sort of functional and metabolic disturbances that accumulate, and you just have to see which path are they going down. Is it autoimmunity? Is it neurologic? Is it cardiovascular? Which triad are we in? But each triad tends to have its own set of forces that we can control, in a sense. Triad 1, it's stress and nutrition and exercise, meaning and purpose and spirituality. Two, it's food, especially as a trigger for inflammation. It's vectors and exposures like infections and mold, for example. And then triad 4, which is liver, lymph, kidney. That's sort of the classic with regard to heavy metals, chemicals, other biotoxins, as well as sort of the genetic potential for methylation and just sort of our expression of detoxification. And then triad 5. And so here we have a more complex testosterone. So as we age and these hormones decline, expression, all of which can really between triad 1 and triad 3. This is the role of visceral adipose tissue, which is very metabolically active, high levels of inflammation that's expressed by adipokines that produce IL-6, TNF-alpha, decrease in adiponectin, which is important for healthy weight. And so you have a localized inflammation that's occurring in fat that surrounds organ tissue. But this in turn will directly impair the peripheral skeletal muscle, which we know is involved in insulin resistance, and as well as signaling of high IL-6 and TNF-alpha, which in turn will have the liver overexpress high sensitivity CRP, as well as PI1. And of course, the liver produces cholesterol, so this is often one location where cholesterol becomes oxidized, so you have oxidized LDL. All of these factors will begin to impart injury on the vascular lining, which in turn leads to endothelial dysfunction, as I've mentioned. The insulin resistance, which is a secondary source of whole body oxidative stress and inflammation. So it's this sort of, as they call, visceral fat or ectopic fat, which can initiate a variety of cardiometabolic risks. And so the body becomes inflamed, it becomes sticky, and the vascular tree, in a sense, is one of the organs, essentially, that becomes compromised as a result of all this metabolic activity. In a global sense, then, we're looking at triad 1 and triad 3. That, stress and blood sugar begin to sort of accumulate in pathological ways, which can lead to insulin resistance, deposition of ectopic or visceral fat, which in turn creates its own risk for endothelial dysfunction through a variety of mechanisms. And so we want to control things on the global level in terms of managing stress, improving the diet, ensuring the gut is not an engine for inflammation. And we hope that we begin to modulate some of these metabolomic factors that are impinging on the vascular tree. If things have progressed in a sense and they're prehypertensive or hyperlipidemic, or they're showing signs of, frank vascular disease, you want to intervene at that level too, but you also want to deal with the drivers of all of this activity as well. One of those drivers, which has been evaluated quite often, is homocysteine in endothelial dysfunction. There's a long history of looking at homocysteine with sort of a disappointing outcome in the sense that it is an expression of metabolism, and in particular the methylation cycle. It's important as part of the link between homocysteine and heart disease, that if the body has poor methylation, we see elevations of homocysteine. It's thought to signal low levels of folate, B6, and B12, and so there's all of this adopting of that idea within the alternative community to say that if we can just improve methylation, we should be able to improve cardiovascular risk. The treatment studies that have been done in the 80s and even the 90s looking at lowering homocysteine through supplementation of folate, B6, and B12 did not see a future reduction of heart disease risk. And so the question is, how important is homocysteine? Well, it's kind of like CRP in the sense that if homocysteine is high, and we think when you really look at the literature tightly, anything above 6 and certainly 10 in the serum is probably too high. Yes, that's a signal of poor methylation. It's a signal that the body has a difficult time detoxifying and has low levels of B vitamins. But it also itself is very injurious to the endothelial lining. So I pulled this study to show that, in fact, it plays that dual role just the way that high sensitivity CRP also plays that dual role. So mild elevations increases reactive oxygen species, and studies show impaired vessel relaxation and buildup of toxic thiolactones. So I like to lower homocysteine because I think it's actually important in the context of a whole body approach. I think that's where conventional medicine always falls short. It's if we just lower homocysteine, we expect that vascular disease gets better. And I just don't think that's how we should be approaching it. We should be using a systems biology approach, and we should be looking at things in context. Do they have stress? Do they have blood sugar issues? Do they have high homocysteine? Do they have high CRP? We don't like looking at things this way because it's more difficult to measure, and we don't know exactly how important each marker is. But this is actually where a lot of research is going. So it's sort of that global outcomes assessment that we care about more than each individual marker. And I think homocysteine really falls into that category. I would say that most cardiologists, while they're sort of course, aware of homocysteine, they probably care less about it than we do in the integrative model. This is just a reminder to say that as ADMA levels increase because of excess oxidative stress, as well as decreased blood flow to the kidneys because of vascular spasm or thickening of the renal arteries, there are all sorts of problems that accrue as a result of kidney damage. And so we have a greater release of proteins and antigens that are actually being released from within the kidneys, which then further cause problems within the vascular system. So there's this sort of cycle of damage that goes in both directions. And so we see compromise of the endothelial cells as a result. And this is all to say that ultimately we will give a direct treatment of, well, how do I deal with kidneys? And I just wanted to put this in there because I know that we tend to overlook them as a key organ that has to be regulated. I think the nephrologist will say that it's one of the most important organs to manage in the context of chronic illness. So this is a reminder as well of what's going on in the blood. So we see fibrinolysis, basically the production of fibrin. So these are, fibrous threads that begin to deposit themselves on the cap of the atheroma in a sense, and it's also part of the signal of all the endothelial dysfunction that's occurring within the vessel lining. There's a relationship between fibrinolysis and coagulation. So the coagulation cascade creates stickiness in the blood, which in turn produces fibrin, and that fibrin lays down across the atheroma. So there's so much activity, as you can see, that's going on as a result of blood-based inflammation and oxidative stress, as well as the activity on the other side of the endothelial lining. So there are problems that occur within the lumen and extraluminally, all of which is to say that we have multiple targets that we have to deal with in terms of decreasing stickiness, improving nitric oxide production, and ensuring that we have low levels of inflammation where we can manage that. This is a model of lipids, and so there are professionals, both primary care as well as cardiologists, that can get certified in lipidology, and it's the notion that we want to look very specifically at a variety of lipids, all of which can have impact on vascular health at certain levels. We know the liver in particular is the organ that produces cholesterol. And I think we look at it maybe a little differently in terms of, the integrative model, that when cholesterol levels go up, we know that there typically is lots of inflammation in the body. It's not just from overconsumption of a high saturated fat diet. Certainly hyperlipidemia can also be driven by a high carbohydrate diet. I think even more important than all of that is what's happening to the lipids as they're floating through the blood. LDL is the carrier molecule for cholesterol to the arteries. Remember, cholesterol is important as a precursor for all steroids in the body. It's also the body's internal band-aid. So whenever there's inflammation or cracking of the vascular lining, that's where the body will lay down cholesterol to cover those cracks. But if we oxidize the LDL in particular, that can lead to a pathological deposition. So we have very low density lipoproteins that then are converted with removal of free fatty acids to intermediate density lipoproteins. If we have overproduction or deposition of IDLs, that's a risk for insulin resistance. More free fatty acids are released from the chylomicrons. And finally, we produce LDL. And there's various forms of LDL that ultimately will deposit within the vascular tree. one of the roles of fish oil, for example, is to reduce or remove free fatty acids from cholesterol particles. And so if you don't have good free fatty acid shuttling from the periphery, it's very hard for these patients to actually lose weight. And one way to do that is reduce inflammation and give fish oils. So we want to have the body convert healthily from one form of cholesterol to the other. In conventional medicine, we typically look at LDL as the primary marker of heart disease risk. Total cholesterol we think is important too. HDL, especially when it goes low, because HDL is what removes cholesterol from the arteries and returns it back to the liver. We want a balance of shuttling of cholesterol to the periphery and then away from the periphery. And so if LDL levels are high and HDL levels are low, we have an overabundance of activity bringing cholesterol to the blood vessels as opposed to away from them. And so there are some mechanisms of raising HDL as well as lowering LDL. Most preventive cardiologists are very, very focused on merely lowering LDL. There are other expressions of LDL, so you can measure LDL directly, or there are other indirect methods. You can also measure separate apoproteins, which are the carrier molecules. There's apoprotein B in particular, ApoB, that we think is the most important as the director of bringing LDL to the vascular lining. So you can measure apoprotein B as well as oxidized LDL. And so there are new methods, lipid profiles essentially, that will give you all of the detail with regard to, what is going on with the lipid status of the individual. And it turns out that there are different sizes of LDL and different sizes of HDL. So the larger the LDL particle, the fluffier it is, it will kind of bounce down the vascular bed, and it doesn't typically deposit in the vascular lining, so there's lower risk. If you have small, dense type LDL, think of them as these hard marbles that are rolling down the vascular lining. They have more of a propensity of falling into the cracks and causing problems and establishing the atheroma. So these newer cholesterol measurement tools will allow you to look at not just LDL, but the size of LDL and the actual particle number of LDL. And we want to make sure that there are healthy amounts of large type LDL. And you can increase LDL through certain strategies like aged garlic or fish oil, or removing saturated fats out of the diet, decreasing systemic inflammation, plenty of fruits and vegetables, managing stress. There's all sorts of ways of improving the size of LDL. And with these newer markers, and certainly Quest Labs will do it. They bought Berkeley. There are, and in addition to SpectraCell, which will also run certain profiles, you can get a whole assessment or array of what's going on in the cholesterol profile. Some of which is driven by actual inflammation, other by diet, and some even from insulin resistance. And you'll get on the report whether or not there are abnormal forms or types of cholesterol particles. So these are called fractionated panels. We don't want to just look at total cholesterol or LDL or HDL or triglycerides. Triglycerides are a measure of sugar intake, but you also want to fractionate the panel, because sometimes the total LDL is high, but when you do a fractionated panel, it's all fluffy LDL. It's all large, type A LDL. So we don't really care all that much. There's not real risk there. So we just really want to know what's protective and what's not. And the thinking has changed over time to some degree. And it's these newer markers and lab kits that allow us to do that. I think Quest actually in particular has a very good one now. They have the most advanced flow cytometry for looking at cholesterol particles. And it really, again, is just the balance of the flow of cholesterol to the periphery and then away from the periphery back to the liver for deposition. And the liver will process that excess cholesterol and remove it from the gut. This is where the old school cholesterol binders like cholestyramine bile acid sequestrants worked in the gut, where they bind up excess cholesterol and remove it from the digestive tract. So all of this is to say there's a process of cholesterol production from the liver, and ultimately that cholesterol will find its way into the vascular system. And again, cholesterol has its own set of properties. It's not just something that's important for blood vessel health, and it is, but cholesterol is used as a precursor for steroids, for example. It even has its own immunomodulatory activity too. And so you want healthy amounts of cholesterol in the body to ensure that you have normal endocrine balance. So this is the vascular summary. This is sort of a short list of the things that you can target when you're looking at your patients to try and understand whether or not they're at risk for vascular disease and endothelial dysfunction in particular. So measures of oxidative stress, well, you don't want to oxidize your LDL. Is there prehypertension because of decreased nitric oxide production? That's a measure of oxidative stress. We know that homocysteine and toxins can also be injurious to the vascular lining. Remember, homocysteine is an expression of poor methylation and B vitamin deficiency, but it also is a marker that can, through thiolactones, directly injure the endothelial lining. And then toxins directly, heavy metals, chemicals, are also their own kind of insult to the vascular tree. And insulin resistance, as I mentioned before. So all of these can lead to oxidative stress. Blood tissue hypercoagulability, so fibrinogen, VCAM, ICAM, platelet activation, so the blood is becoming sticky. You can measure fibrinogen, you can measure Pi1, you can look at the flow of the blood through the vascular system, but there's some nice markers that we can do that are relatively standard. In addition, just measures of inflammation, IL-6, TNF-alpha, you can measure them, but you don't see a lot of people doing that. But you can measure stress, right? So you can get a saliva cortisol test. If it's low, you know that in a relative sense, there has to be higher levels of IL-6 and TNF-alpha because you've lost competency or control on the immune system. So when a person has been under chronic stress and they flatten their cortisol curve, we know they have greater risk for heart disease. High sensitivity CRP, which is a direct measure of vascular inflammation, a very robust marker. It's used all the time in the cardiovascular literature. One of the new ones that's now in vogue, it's an old test that has come back in a sense, is uric acid. Uric acid, as a measure of whole body inflammation, is also very important, and the literature is actually growing in this regard. And then finally, increased permeability, this notion that just like the gut can be permeable, so too can the blood vessels. And so you can get microalbuminuria, which you can measure in the urine. So a lot of these are relatively easy to measure, and they can begin to build a framework for whether or not the blood vessels are compromised. So what we then have is this stacking idea of Triad 1 and Triad 3, that we know that as the patient becomes more insulin resistant, if their blood sugar is climbing above 84, let alone 90, if their fasting insulin is above 10, and certainly above 22, if they have nutrient deficiencies with vitamin D or magnesium or chromium, they will have accelerated risk for diabetes. You can measure that through an hemoglobin A1C in addition to the standard markers. You can also measure stress. We've talked about this with respect to either a serum measurement of cortisol, healthy is 10 to 14, above 14 it's getting a little high, or more importantly, if they flatten their cortisol curve, if they have impairment of the hippocampus and hypothalamus, the brain has finally said enough is enough. We see lowering of the cortisol response in a self-protective effort. But unfortunately, because cortisol is the brake on the immune system, with low cortisol levels, you have liberation of IL-6, TNF-alpha, CRP, and it's all over the literature. We know that when patients have a flattened cortisol curve, they are at higher risk for vascular disease. And then thyroid. So thyroid not only drives all cell energy production in terms of ATP, but it's also particularly important for the heart itself. And so when we have low levels of free T3, we lose competency in the cardiovascular system. It predisposes to insulin resistance. It means that that cell metabolism is shifting from a normal oxidative aerobic state to a glycogenic state, meaning that we're much more inefficient at burning sugar at the cell level when we have low levels of T3. So all of Triad 1 really has a direct relationship with Triad 3. So just as a reminder, adrenal, thyroid, pancreas, it's about energy production. We know that we need adequate insulin response to be able to burn sugar. We know that we need to have competency in our stress response to have plenty of energy to deal with stressors. And thyroid produces ATP at the mitochondrial level. So every cell in the body is dependent on thyroid to produce cell level energy. And so all of this is to say that when they're normal, when we're eating a healthy diet and we're managing our stress appropriately and we have a healthy thyroid function, we have plenty of energy. And when we see a diminishment in these activities because they become compromised or overwhelmed, we see lower levels of energy output. When I explain it to my patients, I talk about stress, metabolism, and sugar. It's always how I characterize it to them so they can understand. Yeah, I'm under a lot of stress and I feel sluggish. I feel like my metabolism is slowing down and I'm craving sugar. Those three issues tend to go together, and that's what reflects in an imbalance in Triad 1 because it's a central regulator physiology. When you think about it, we eat every day, we experience stress every day, we have to rest and relax at night. So all of these inputs that constantly influence Triad 1 are always there. And when they're in balance, people feel vital and well, but when they're in balance, we tend to gain weight and we're tired. The characteristics, again, it's that being in rhythm with the outside world. These hormones need to move. When they are activated, we see increased levels of insulin when we eat, and that's appropriate. We see increased levels of cortisol when we have stress. We see fluctuations in thyroid hormone due to energy requirements. And so there's a rhythmicity to the changes in Triad 1. When we lose that rhythmicity, when we lose competency in our ability to handle carbohydrates or manage stress appropriately or deal with the energy demands of the world, we can lose vitality. And I also think of this as operating on a spiritual level in terms of who are we in the world, and are we getting overwhelmed by forces and factors? And how does that translate in terms of meaning and purpose? Are we losing meaning and purpose? We can see the influence within Triad 1. This is the earliest change. It's a secondary disturbance where the individual is eating too many sugars. And so there's an elevated fasting insulin or challenge, an elevated fasting glucose. We know the body tries to compensate for the fluctuations in blood sugar by increasing cortisol levels in a relative sense to blunt the lowering of blood sugar and insulin so they're not swinging as high. So there's a commensurate or compensation to an elevated blood sugar through the stress response. And when those are activated, we see a diminishment of production of TSH from the brain, as well as impaired conversion from T4 to T3. But usually these are early changes, so we don't have an expression yet of immune dysfunction. So there's no autoimmunity that's typically going on in the thyroid itself. And in fact, just the opposite, the adrenals with elevated cortisol will begin to suppress immune activity, which creates its own set of vulnerabilities, especially within Triad 2 with regard to neuroexcitation. The secondary disturbance, this is an individual who's progressed, and sure, they have blood sugar related issues, but they've overwhelmed their stress response and they've flattened their cortisol curve. There's a liberation of the immune system as a result. There are likely brain related changes as well, especially within the hippocampus. And this is that state that creates enormous risk for the individual because now the immune system has been activated. And if they have a current disease, breast cancer, heart disease, diabetes, autoimmune diseases, all of those diseases are made worse with a flattened cortisol curve. And it's because of a dysregulated immune system. So when you're talking to patients about stress, especially if they flatten their curve, I don't just talk about, well, we need to raise your cortisol. We also need to talk about the other side of the coin, which is modulating the immune system. And so this is here the invocation in a sense of Triad 2, because we know that if they flatten their curve, they've likely had brain-related changes and they have alterations in their immune system. As well, if you recall from our lecture from Triad 2, high cortisol levels will dissolve the gut lining, literally, because cortisol is catabolic. It'll do the same to the vascular tree. So it can predispose people to food sensitivities, and as that lining becomes even more compromised and a greater triggering of the immune response, especially if they go from a high to a low cortisol output, we see an overproduction of the immune response in relationship to food. So this is a very pathological state for the individual to be in. They have clearly problems within Triad 1. When you flatten your cortisol curve, it makes your blood sugar work even harder. When you flatten your cortisol curve, we see an even greater impairment on the thyroid axis. But as of yet, we categorize this as a secondary disturbance that has not yet released the immune system into an autoimmune state, but they could get there, and there's no doubt that they could get there. And then finally, thyroid dominant. This is the greatest expression. It looks like cortisol dominant, but now we have the presence of autoimmunity. And so I think, you know, the flattened cortisol curve, the food triggers, the exposures, infections and vectors begin to all load into the immune system, and now the immune system is autoimmune, and it's targeting the thyroid in a sense. And so we have tissue level destruction that's going on. Interestingly, this is also likely occurring in the beta cells in the pancreas, which we think is a precursor or indication of the initiation of beta cell destruction. It's not just categorized now as type 1 diabetes, as a frank autoimmune disease, but we think there's this same process going on in a low-grade fashion in type 2. So what are some of the supplement recommendations that we've gone through in Triad 1? Well, the big three for nutrients is chromium, vitamin D, and magnesium, as well as lipoic acid, which is very important for blood sugar control, fish oil, which again helps to liberate free fatty acids from the periphery, bitter melon, cinnamon, sterols, arginine, and I would also add in bergamot. I think that's one of the other really big ones. So the holy trinity of nutrients, in a sense, is chromium, D, and magnesium. You have to replace those to adequate levels, and then lipoic, fish oil, and bergamot, I think, are really the strongest now as a grouping for fixing blood sugar-related issues. In terms of stress, this is a little harder. Remember, you need to modulate the stress response, protect the brain, decrease inflammation, and reduce cortisol where appropriate. You can do that through magnolia and philodendron, which is relora, theanine, which is a green tea extract, and holy basil. You can also support the adrenals with glandular extracts. You can use the whole gland or a cortex extract, depending on if they're anxious. Of course, we like the adaptogens, ginseng, ashwagandha, maca, rhodiola, as well as the higher level extracts like an RG3 or a nicotinamide riboside, which are particularly neuroprotective. There's neuromedulla, which is a glandular that helps to reconnect the hippocampus to the hypothalamus. DHEA, which is the antidote to cortisol. It's specifically neuroprotective. And then tryptophan, which helps with mood. And then finally with thyroid, selenium, theanine, iodine, chromium, thyroid glandular, tyrosine, and ferritin. Selenium and iodine, chromium, and ferritin all help with the conversion of T4 to T3. You can opt for an over-the-counter glandular if both T4 and T3 levels are low, if you don't want to prescribe a medication. And then tyrosine and iodine are what form thyroid hormone. So all of this is really important for individuals who are imbalanced in Triad 1. So what happens, though, if we move beyond vascular related inflammation and oxidative stress, and now we begin to invoke this sort of systems-based approach where there are even greater pressures that are impinging on the relationship between the heart and the brain as mediated through the vascular tree, and that is this heart-brain connection. And it's expressed through the balance of the sympathetic and parasympathetic nervous system, which is our autonomic nervous system. And there can also be a genetic contribution at this level as well that can compromise both the heart and the brain at the same time. So let's look at emotions in the heart. This is this new field of research called neurocardiology. It is the relationship of bidirectional flow of information between the central nervous system and the heart. That flow of information in part is mediated by lung function and the peripheral nervous system. And there are these key or core concepts called resting heart rate and heart rate variability. So the heart communicates with the brain and the body in 4 ways. It's amazing, the relationship here. There's the neurologic communication within the autonomic nervous system. There's biophysical communication. It turns out the brain senses pulse waves that are coming up from the heart. There's biochemical communication. There are hormones that are released from the heart that the brain senses. And then there's the energetic communication, or the electromagnetic fields that are produced both within the heart and the brain. Extraordinary amount of sensing that's going on between these two organs within this triad. So it's not just about the vascular tree in terms of the forces and factors that are leading to cardiovascular disease, but it's the more global set of relationships that are occurring between organ systems. And so here we have a model of that, the brain with regard to the cortex, the subcortical areas, and the medulla, and as they relate to the balance between sympathetic or efferent outputs, which is the spinal cord. These are the activating nerve pathways for the sympathetic nervous system. And when we're under stress, when we become activated and we're dealing in the world on a robust basis, it's the sympathetic nervous system that's taking over. And among other things, it's driving the information down to the level of the heart into the sinoatrial node, and it's telling the heart to beat faster and to keep up with the peripheral oxygen demands of our skeletal tissue. And so that as we're dealing with stress in the world, we're telling the heart to keep up, in a sense. And so the sympathetic nervous system is sending those signals adequately. As a break to this, the afferents that are coming up from the heart to the brain, in a sense, is the vagal nerve. And so this is, a cranial nerve that is an output, and it's the parasympathetic side. It's the, hey, slow down, keep balance, relax, go into repair mode. Parasympathetics also innervate the gut. They innervate the kidneys and other organs. And when the parasympathetic side of the nervous system becomes active, we can go into digestion and rest and repair. And it slows the heart down. So we want a balance between the sympathetic and the parasympathetic. Both are important, and there needs to be tone appropriately within each. But if you have overwhelming output or underwhelming input of the afferents coming up through the parasympathetic systems, we can have sympathetic dominance in a sense, and this can impair or impact the heart. So you can see how systemic inflammation can lead to vascular inflammation, and that vascular inflammation is what predates or relates to endothelial dysfunction and can lead to acute coronary syndromes and plaque rupture. And of course, when you have frank vascular disease and coronary artery disease in particular, we have decreased cardiac function. So we know that there is this relationship that I'm going to go to in greater detail. But here are these concepts of decreased vagal tone, so decreased parasympathetic activity, which in turn can lead to increased systemic inflammation, which in turn can lead to vascular disease. So what is this sympathetic overdrive? It's the imbalance between the sympathetic and parasympathetic nervous systems. There's direct innervation of the sinus node, which I talked about, and increased sympathetic nervous system activity due to affective disorders, meaning mood disorders like anxiety and depression, as well as chronic stress, and neuroinflammation. So the brain is on fire due to gut immune brain related abnormalities, or even Triad 1 related abnormalities can lead to increase in sympathetic activity. This leads to elevations in resting heart rate because you have greater signaling or neurologic input into the sympathetic side of the nervous system. So we know these patients who are under sympathetic activity, they have elevated resting heart rates. That is a very robust marker for sympathetic overdrive. So what does this mean on a more kind of clinical level? So mood and heart disease. Up to 60% of patients with an acute coronary event experience symptoms of depression within 12 months following the event. Depression following acute MI doubles risk of mortality in the months following the acute event. We know people who are depressed or inflamed, and we think there's this relationship. I talked about this in great detail in Triad 2 with gut immune brain. So just having symptoms of depression at various times in the course of heart disease doubles the risk of death, and that clinical depression is associated with an even higher risk. So when you have this relationship between the brain and the heart, a mood disorder and known heart disease, it greatly increases the risk of death in those patients from a cardiac event. And this is where it gets really interesting. When you look at the relationship between emotions and the heart, I talked about sort of inflammation and spasm, that a Triad 3 imbalance is an outward imbalance, meaning there's a great amount of energy that's being expressed through arrhythmias and heart attacks and strokes and so on and so forth. It's very obvious, but emotions are kind of like that too. So separate studies showed that the risk of developing heart disease is significantly increased for people who impulsively vent their anger as well as for those who tend to repress angry feelings. And that is to say that, we have these, we have these issues that are accumulating over time that are creating, sort of an expression of Triad 3 imbalance, and anger being one of them. Can be a productive emotion, but it can also be destructive. And it seems to be particularly destructive in the context of heart disease. It's this very interesting idea that sort of our mind and psyche kind of follow physiology in a sense. So mood and heart disease, depression linked to reduced adherence to treatment regimens, increased prevalence of smoking and diabetes, platelet dysfunction and coagulant processes. So interestingly, in some ways it makes sense that if you kind of buy into this model of an inflammatory component to mood disorders, it makes sense that there's platelet dysfunction and hypercoagulability. Alterations in the HPA axis. I've mentioned this before, but I'll remind you that high cortisol levels tend to be associated with what are called treatment-sensitive depressed states, meaning that these people respond better to conventional medications like SSRIs and SNRIs. But when you flatten your cortisol curve, this is called treatment-resistant depression, that there's liberation of the immune system, systemic inflammation. These patients are much harder to treat from a mood perspective. There's autonomic nervous system dysfunction, meaning that there's sympathetic overdrive, as well as increased inflammation and plaque rupture. So we know patients who are depressed, as I've mentioned, are at greater risk for acute coronary events. So depression links with decreased vagal tone, which links to increased inflammation and coagulation. So mood and vagal tone. There is this notion of increased IL-6 and TNF-alpha. So increased CRP, fibrinogen, increased resting heart rate, and decreased heart rate variability. So what's so important about heart rate or resting heart rate? Well, it turns out there's a remarkably strong association between heart rate and survival, an association that transcends species. Small mammals that have rapid heart rates have short life expectancies. Larger mammals that have slower heart rates have correspondingly higher life expectancies. And among nearly all mammals, life expectancy is close to 1, or even for newer estimates, 2 billion heartbeats. So there's a range in terms of how many heartbeats do we get. And at some point, if you constantly are activating your sympathetic nervous system and driving your resting heart rate, we know that there's kind of an expiration date for us. And investigators have been able to increase survival in animal models by deliberately slowing the heart rate. For resting heart rate, as heart rate increases to 75 to 80 beats per minute, there are marked increases in total mortality and mortality due to coronary heart disease. Interestingly, beta blockers reduce mortality in survivors of myocardial infarction, and the magnitude of reduction in mortality with beta blocker therapy is directly proportional to the magnitude of heart rate decrease. So if you can slow the heart rate down, you're actually improving mortality risk. You're helping people live longer just by slowing the heart rate. Incredibly robust relationship. So here we have resting heart rate by quintile. These are women with heart disease, and the cutoff is around 76 beats per minute. That's when it really crosses the 1 for confidence interval. And so we know that when patients have a higher resting heart rate, somewhere in the mid-70s, essentially, there is a increased risk for heart disease. And basically what it's saying is there's increased sympathetic tone, and that the body's not going into rest and repair mode. We don't activate the parasympathetic nervous system. And so there's this other notion that I quickly mentioned, and yet stands at the center of these relationships, and this is something that we're going to focus on. It's called heart rate variability. And heart rate variability is a reflection of sympathetic dominance in the heart rate itself. And it's an expression of a notion that the heart was never meant to beat like a metronome, that there's actually variability in the timing of beat to beats. And so we've known that there is this variability even before the EKG was developed, and that it normally varies with respiration. So when we breathe in, the heart rate accelerates, and when we breathe out, it decelerates. And this is called a respiratory sinus arrhythmia, which can be demonstrated by plotting heart rate over time in resting supine subjects. And so when there's a linking of the overall heart rate with breathing. When there's coherence, in a sense, where the heart is talking with the lungs, we know that there's a healthy connection there. If we don't see an accelerated heart rate with breathing in or deceleration with exhalation, then we know that there's a real problem with sympathetic dominance. A lot of this is actually being driven in the brain, that in fact, the linking of the heart and lungs is mediated through how we feel. It's feeling states, in a sense, and whether or not we're calm and we have adequate control of our mood. If we don't, then there's an unhinging. There's a disintegration in these set of relationships. This is that notion of coherence, that when the brain is healthy and the heart is healthy and the lungs are healthy, we see adequate heart rate variability or an adequate respiratory sinus arrhythmia. And when we have problems with systemic inflammation, when we have problems in our cognition or mood, when we have problems in our vascular tree, we see changes in our ability to have coherence. So this is a graph of the expression of heart rate variability in particular. So heart rate variability is very simply the timing from beat to beat of the heart rate. And it turns out that there should be, by definition, variability in the timing. That when there's flexibility, when there's a little bit of erratic timing, this actually indicates a nice balance between the sympathetic and parasympathetic inputs into the sinoatrial node. That our heart was never meant to beat like a metronome. And that this is not necessarily an observable phenomenon, but it is a mathematically measurable phenomenon. And that's what this graph shows. That if you look at an EKG over time and you evaluate the milliseconds of timing in beats, and you translate that in what's called a Fourier distribution, you can measure what are called high frequency beats, low frequency beats, and very low frequency beats. The low frequency and very low frequency beats are a measure of decreased heart rate variability. We are losing the flexibility and unpredictability of timing from beat to beat in a millisecond fashion. When there is high frequency, the presence of great variability in timing, we know the heart is healthy. And it is an indication that there is this kind of back and forth that's going on between the sympathetic and parasympathetic parts of the autonomic nervous system as they signal that sinoatrial node. That's what we want. We want balance. And there are a few reliable ways of activating that parasympathetic response. And breathing techniques are one of them. And so this is a phenomenon that has not only been measured, but measured extensively. And we know that when there is nice tone and adequate heart rate variability, people are healthy and they have nice coherence between the brain and the heart, the mind and the spirit. And it is mediated through that lung function. So that presence of the respiratory sinus arrhythmia, it is also a global indication of elevated heart rate variability. As we become stressed, as we activate the sympathetic side of the nervous system, and I mean stressed emotionally as well as physiologically. So when we see the presence of vascular disease and diabetes and PTSD and chronic inflammation, we have overactivation of the sympathetic nervous system, therefore decreased heart rate variability. And this is a reflection of the state of physiology of the body, that the body is stressed and inflamed. So heart rate variability. Decreased heart rate variability has been linked to cardiac events and mortality. And among healthy elderly subjects enrolled in the Framingham Heart Study, decreased heart rate variability has been associated with increased major cardiac events. So there's an association between measures of heart rate variability and cardiac events, and we can see how with the progression of low frequency to high frequency, there is a marked increase in cardiac events. So what decreases heart rate variability or decreasing vagal tone in a sense? Obesity does it, so just general systemic inflammation. The state of insulin resistance and diabetes also decreases heart rate variability. So we're in Triad 1. The state of hypertension, hypercholesterolemia have both been linked with decreased heart rate variability. Depression and anxiety, so mood-related disorders, a gut immune brain expression, also linked with decreased heart rate variability. Heart failure and peripheral vascular disease have been linked with heart rate variability. Now, it's not clear if it's the heart rate variability that came first or the end organ damage. But all of these instances of Triad 1, 2, and 3 have been linked with decreased heart rate variability. And so here's a model. It is a very direct linear relationship that as fasting plasma blood sugar climbs, so too does the prevalence of abnormal heart rate recovery, which is just another way of saying decreased heart rate variability. So cognition and cerebrovascular disease. Depression is associated with higher rates of MI, which is heart attack, coronary artery disease, congestive heart failure, and arrhythmias. Myocognitive impairment is associated with cerebrovascular disease. Depression, myocognitive impairment, and cardiovascular disease are linked, but these links are not well understood. But you can use these in-office measurement tools, such as a PHQ-9, which is a 9-question scale. We've talked about this before with respect to quick and dirty on assessing whether or not depression is an issue with a particular patient. So we know there's an overlap between cognition, mood, and heart disease. And on the mood side, you can use a PHQ-9, which is a nice validated scale. That's actually part of what you're learning for next week. So just as a reminder then, stress impairs gut-immune brain. We see a dissolving of the gut lining due to mast cell release, as well as direct increase in permeability from cortisol. Remember, when cortisol levels are high, mast cells are triggered and histamine is produced. So it's a Th2 dominant state. The body becomes more leaky. The gut becomes more leaky. The blood vessels become more leaky under stress, and so too does the blood-brain barrier and the brain itself. There's tremendous amount of histamine that is released as a result of increased stress. As well, there's a new marker called diamine oxidase, DAO, is the enzyme that breaks down histamine. Some people are impaired in their diamine oxidase. You can support DAO. I think Zymogen sells a product to support DAO. You can also use histamine blockers like quercetin or bioflavonoids, which decrease histaminic activity. So patients become leaky as a result of stress. And that leakiness can lead to excess immune activation because food immune compounds are being produced, which in turn creates systemic inflammation, immune activation, which the brain senses because of all of that nervous system mass in the gut, as well as those circulating immune factors that get into the brain. So the brain becomes inflamed as a result of stress. And so this is that stacking relationship between Triad 1 and Triad 2, which is so important to recognize. Remember the neurodegenerative model of depression. It begins with inflammation in the gut with activation of indolamine. So we see shunting away from serotonin in the gut and down to quinolinic acid, which is directly injurious to brain tissue. We think this is one of the major models by which people become depressed. So as the gut goes, so does the brain. If the gut is inflamed, so is the brain. And one of the expressions of that is anxiety and depression. We see this over and over and over in the literature. So if the brain is inflamed, that means there are all sorts of other peripheral changes that will occur. But the gut can be an engine for that systemic inflammation, which is expressed through the mood in a sense. And remember, there's all sorts of things that increase indolamine activity. So emotional stress, as well as medications and toxins, all of which create dysbiosis, gut-related inflammation that raises IDO. There's a tremendous amount of literature on this particular enzyme. It is worth doing a Google search on IDO. You will be surprised by the amount of diseases that have been linked to excess indolamine activity. So here we have that relationship between Triad 1 and Triad 2 expressed through mood. And we know that, in fact, if you flatten your cortisol curve, this all just gets worse. But again, it's looking at a set of stacking relationships that, we in medicine tend to treat the depression, but what we really want to do is treat the problem or cause. So this is to say there is a relationship between gut immune brain and cardiopulmonary neurovascular, Triad 2 and Triad 3. Stacking once again. So gut immune brain, primary command and control, filtering and defense and repair. These are major physiologic interfaces. It's our ability to take in and let go. It's security and safety in the world. nutritional security, immunologic security, and psychic security. And when this particular set of relationships begins to break down, you can have functional disturbances that can accrue over time that can lead to immune dysfunction as well as cognitive issues. And when it's imbalanced, it's disordered and unpredictable. And as I mentioned, this is the triad where the energy of it is sort of eating the person up inside. They have tremendous anxiety and depression, they have inflammation and autoimmunity, and they may even develop cancer as a result of all of this disorganization. So they're not safe. They're not safe from their own body, meaning when is my irritable bowel going to flare? When is my rheumatoid arthritis going to flare? Am I at risk for cancer? And all of this is to say that there's this kind of dissolution or dissolving of physiology when Triad 3 becomes imbalanced. This is not the triad where the ambulances show up. This is that very quiet, slow death, in a sense. And it's a very different energy from Triad 3. But when it's healthy, it's a wonderful set of systems that gives us so much security and safety in the world that we remain organized and able to sort of handle all sorts of threats and exposures. And it's our ability to kind of take in those threats and let them go appropriately. So it's that cell level intelligence as well, this notion that the gut is making decisions on a moment-to-moment basis, but it makes mistakes, so the immune system has to step in and make sure that it cleans up any residual issues. But the immune system can make mistakes and become chronically inflamed or autoimmune, and the brain senses this, so neuroinflammation. And also that psychic notion of safe borders and boundaries in who I am in the world. And you can have sort of relationship threats as well as physical threats. And when we know ourselves and we have good decision making, we tend to make good decisions, and that keeps us secure. And when all of that begins to break down, we don't feel grounded or centered. We feel like things are running out of control, in a sense. So gut-brain pathology, this is the earliest disturbance. So when we're under stress, there's usually that functional expression of irritable bowel and depression. We can also have a further impact. So we go from a functional disturbance to invoking the immune system. We can see presence of food sensitivities, an increase in white blood cell differential, which again is the summation of the percentage of monocytes, eosinophils, and basophils. If it's trending high, 7, even 10 or higher, we know the immune system is beginning to aggregate along the gut lining. There can be a genetic predisposition to gluten sensitivity, as well as known exposures to toxins as well as biotoxins, which are impairing the immune system. These can be heavy metals or chemicals. It can be mold or infections, any one of which begin to create dysfunction within the immune system. And as the immune system becomes inflamed, we can see alterations in the central nervous system. So abnormal cortisol curves, especially flattened cortisol, is a reflection of systemic inflammation. There could be impairment on the genetic level in terms of methylation, as well as inflammation in the gut, lowering tryptophan and shunting away to quinolinic acid. And then finally, a complete expression of gut immune brain pathology, and that is to say, clear levels of elevated CRP, SED rate, IL-16F alpha, true markers of autoimmunity, frank measurements of toxins, vectors, infections, maybe a double SNP on the MTHFR, as well as an elevated beta-2 microglobulin, which is an expression of degradation of the blood-brain barrier. So this is someone who's sort of a fully realized, fully compromised Triad 2. And here are all of those supplements that go along with this to help to begin to restore a normal gut-immune-brain balance. You've seen this before. We know that depression, vascular disease, and mild cognitive impairment are all related. So this notion that cognition can be an expression of a gut-immune-brain issue, depression can be an expression of a gut-immune-brain issue, and all of which can load as factors into vascular disease. So this is that relationship, the odds ratio of vascular events related to depression, and we know that the greater the depressed person, the higher the risk for heart disease. There's also a genetic component to this, which is interesting in its overlap. So there's ApoE4, which you can measure, and it's an increased risk for Alzheimer's and cardiovascular disease. It's a key regulator of cholesterol transport, but also enzymatic regulation of amyloid disposition in hippocampus and other memory centers. So in fact, if you have an ApoE4 abnormality, it means that, yes, you have problems with cholesterol transport, but you also have an overexpression of plaquing, essentially, within the hippocampus, which is a major memory center. I've talked about this in the context of the stress response. So if you have someone who's been overwhelmed by stress and they have presence of an allele of ApoE4 or they're homozygous, they have a much greater risk of memory decline. The same is true for MTHFR. I know there's a lot of buzz on MTHFR. Look, there are many genes that are important to us, and MTHFR is just one. But this one is relatively important in the context of that heart-brain pathology. So it's a risk for treatment-resistant depression and cardiovascular disease. So if they have an impairment in their ability to methylate, we know that patients tend to be more depressed. And as well, they tend to have a harder time with their homocysteine levels. So it underlies the homocysteine and methionine pathway, it participates in neurotransmitter and hormone activation, and aids in the ability to remove toxins. And so here's a study looking at ApoE4, so among ApoE4 carriers, baseline cognitive performance appeared particularly worse for those with cardiovascular conditions such as transient ischemic attack, carotid endarterectomy, or untreated hypertension. These epidemiologic studies are consistent with experimental findings that non-demented subjects with ApoE4 have more atrophy in the hippocampus. So here again, we have the hippocampus. We know stress will alter it, but also having an ApoE4 allele will increase risk. And it will decrease glucose metabolism in temporal and parietal lobes. In addition, human neuropathological analyses and mouse models demonstrate that inheritance of an ApoE4 allele raises steady-state levels of amyloid beta in the brain, basically plaquing in the brain, which accumulates in plaque deposits in Alzheimer's disease. So this notion that can be a genetic predisposition, I think, really underlies the link between the heart and the brain, because ApoE4 changes increased risk for cholesterol-related abnormalities as well as memory-related problems. And then you throw stress on top, and now all of a sudden you have a real issue with patients' memory. So ApoE4 carriers with subclinical heart disease are at high risk for decline in cognition, can be measured by serial mini mental status exams, although additional cognitive scales may be required. So we know the mini mental status is really for a primary care in-office assessment tool to just get a baseline sense of whether or not their memory is intact. Easily found on the internet. We've posted it for you for week 2. And you can see clinically significant if the mini mental status score drops by 4 to 5 points across years. So sure, you can do brain imaging studies, you can do neuropsych testing, but you're down and dirty as a baseline kind of, if you want to call it a vital sign for the brain, is a mini mental status exam. But it has to be done over time. You want to get a baseline and check it yearly in your patients. Just like you want to check a resting heart rate, if not heart rate variability, as well as cortisol and some of these other markers that I think are very, very important for overall health. So here we have, we're going to go back to the model now that I've given you a reminder of the relationship between Triad 1 and 3, 2 and 3, but now you understand better the role of the balance between the sympathetic and parasympathetic nervous system. And one of the things I would mention is that, interestingly, the sympathetic nervous system also innervates with the immune system, and so too does the parasympathetic. It turns out that high levels of neurotransmitters on the sympathetic side, like norepinephrine and epinephrine, will stimulate immune cells. They actually stimulate production of IL-6 and TNF-alpha. And at the same time, when the parasympathetic nervous system is activated, we see a turning off of the immune system. And this is exactly where a lot of these new research areas are going with respect to the role of implantable technology for chronic inflammatory processes and even autoimmune diseases. This notion that if you can stimulate the parasympathetic nervous system through nerve impulsing with an implantable device, you can actually turn off immune activity. But we have an older way of doing that, and that is trying to rebalance the relationship between sympathetic tone and parasympathetic through calming the breath and creating awareness. And certainly there can be a very sophisticated set of tools with respect to that, but that's the basic idea. Those tools, we're having you watch a video or two online with respect to heart rate variability and sort of all the ways that you can begin to measure this. There are additional markers with respect to heart rate variability, but I want you to understand the core concept, and that is when you lose vagal tone, when you have sympathetic overdrive, an elevated resting heart rate, especially above 76, as well as further factors that we know impair the autonomic nervous system. So brain-related inflammation. We talked about depression, PTSD, as well as the state of obesity, insulin resistance, and diabetes, hypertension, hypercholesterolemia, of course, direct risk factors for heart disease, depression, anxiety, direct risk factor for heart disease, and then an expression of that, heart failure and PVD. All of these link to systemic inflammation. So one of the ways to think about it is that if you have decreased heart rate variability, you're inflamed. And that inflammation is directly injurious to the blood vessels. So here we have Triad 1, gut immune brain. Adrenal, thyroid, pancreas. That obesity, insulin resistance, and brain-related changes due to stress will lead to decreased heart rate variability. So that treatment-resistant depression, systemic inflammation, changes in the hippocampus, peripheral insulin resistance, decreased thyroid function, all of which can load into this relationship between Triad 1 and Triad 3. But it doesn't stop there. We also have the expression of Triad 2. We talked about gut-related inflammation, the expression of depression and cognitive decline, how the brain first becomes inflamed and then degenerates essentially because of all of that inflammation that can be driven from the gut, as well as toxins and infections and other vectors and forces that begin to shape the balance of Triad 2. So we have depression, anxiety, psychiatric meds and disorders, neurodegenerative conditions, all of which have been linked with decreased heart rate variability. But this is the loading set of factors that can lead to that very subtle change in the endothelial lining. As much as imbalances in the gut milieu leads to leaky gut, we then also have the same loading that can occur across the vascular tree. And this is what predisposes to reduced nitric oxide production, accumulation of ADMA, NF-kappa B, reactive oxygen species, and we begin to see changes in the blood tissue as well with platelet aggregation, adherence, oxidized cholesterol particles, all of which predates a true vascular disease. So this endothelial dysfunction is so important. We can look at all of these risk factors now, whether it's within Triad 1 or Triad 2 or directly within Triad 3, as I've mentioned, for both vascular-related and neuro-related, and heart rate variability being more on the neuro side. But the problem with all of this is that as we load, at some point, there's plaque rupture or an acute coronary event. Again, many times we don't see an accumulation of atheromas, but sometimes we do. But we want to take care of all of these loading risks to make sure that the vascular tree remains compliant. Because if you don't, it can lead to cardiac dysfunction and heart failure. This is tremendously important for patients in this respect. And so we want to prevent the impact of Triad 1 and Triad 2 on Triad 3. This is exactly what my cardiology fellows are saying, is they can't believe how elegant this system is with respect to what they used to do compared to what they now do. Yes, they'd hand out statins for high cholesterol. They'd hand out blood pressure meds to control blood pressure. They'd counsel people on losing weight and trying to prevent, blood sugar issues. They talk about stress in kind of global ways, but they didn't have the tools to really assess what's going on metabolically with their patients and how do you really even potentially reverse the damage. Well, the model of systems biology as mirrored through Triad 1, 2, and 3 begin to give them a pathway with respect to dealing with cardiovascular disease and cognitive decline at the same time. And again, as the heart goes, so does the brain. It's the heart-brain connection. It's the mind and spirit. And when things are functioning normally and we're relaxed and calm and full of good spirit and robustness, we have strength in the world. And unfortunately, we can begin to decline in terms of our memory as well as heart function if we don't take care of the relationship between that brain-heart connection. And again, one of those subtle linking mechanisms is through the breath. This gets back to the oldest healing traditions in the world, and how we can slow the breath and create coherence, increase heart rate variability, decrease systemic inflammation, improve the mood, induce stress resilience, repair damage, and really, now we just have a model for that. And in some ways, I think of how acutely aware these older healing systems have been, and all we're doing is sort of just backfilling the science to show where these things really shine. Here's just a review of the stages for heart failure. I just put this in there because I know some of you aren't thinking about sort of pump dysfunction in your normal daily practices, but we care about this both from a conventional as well as integrated perspective, and there are stages of this essentially. So causes of heart failure, most of it is ischemic heart disease, smoking, again, hypertension, obesity, diabetes, and valve disease. But we want to focus on the modifiable. At risk for heart failure versus frank heart failure. You can review this at your leisure. This is a very conventional slide, but I just wanted to put this in there to remind people of, how do we go from sort of that functional disturbance all the way down to frank pump dysfunction. There are zones of heart failure that you want your patients to focus in on, and usually we have them measure their body weight because it's a assessment of fluid status. And when the heart is not pumping blood through the vascular tree appropriately, the fluid begins to accumulate in the body tissue, and people are gaining fluid weight. So we want to make sure that we're shoring up those blood vessels, helping the heart pump more effectively, creating energy in the cardiovascular system, and I'll talk to you about ways to do that. So Triad 3 is its own universe with respect to what to do, but we have this extraordinary stacking that occurs between Triad 1, 2, as they impart their influence on Triad 3. So we start with the early changes. These are essentially silent symptoms with respect to early vascular disease. You might see someone who has anger and outbursts. They might just be someone who has a lot of kinetic energy. They're very vibrant. But I'd also have you reflect back on Triad 1 symptoms, because Triad 1 really impairs forces on Triad 3, or imparts forces on Triad 3. So what are some of the measures? Well, with respect to prehypertension, and I know these levels keep changing, we just saw JNC 8 criteria come out on how to define hypertension as well as when to treat. But certainly you want to keep people below 135 over 85, if not below 120 over 80. Below 120 over 80 is really now the new standard. And yes, you can do a 24-hour assessment of blood pressure. You can see whether or not they're called spikers or they're spiking at night. We know that if they're getting great fluctuations in their blood pressure over the course of 24 hours, that's even more harmful to the end organs than if they just have the steady state of elevated blood pressure. But as a quick and dirty, anything below 135 over 85 is a target, and certainly below 120 over 80. The dyslipidemias that I mentioned, not just an elevated LDL, but an oxidized LDL, or if they have increased particle number or decreased particle size. An elevated homocysteine, certainly above 6, we think is important. Urine microalbumin, anywhere between 30 and 300, could signal leaky vessel. Increased high sensitivity CRP, our goal is we want to keep them below 1. Fibrinogen above 430 is a risk. Traditional cardiac risk factors, smoking, family history, as well as Triad 1. So that's where the diabetes and obesity and stress come in. We don't see real changes on the neuro side at this point. These are just all factors loading into the vascular tree. So their mood is okay, their memory is okay, they have a normal resting heart rate, they don't have the presence of genetic markers that might predispose them to cholesterol issues or cognitive decline. So here we have one of our example cases. This is our early disturbance, Joan Johnson. She's a 43-year-old ad exec who lives in New York City, a city that never sleeps, and neither does she often. She loves her cigarettes and caffeine. She's kind of like a flickering flame. She loves to go out. She's very social, but she's prone to some anger and outbursts, and she has a family history of heart disease and a mildly increased LDL. So here we have a progression. And so this is someone who moves on from the silent symptoms and angers and outbursts to
We're beginning to see depression or cognitive decline, an expression of stress and fatigue. So they'll talk about nerves being frayed. There might be cool extremities with reduced peripheral circulation, palpitations. So we're developing sort of irritability in the vascular system, particularly the electrical nervous system around the heart. And then finally, Triad 2 symptoms. So Triad 2 loads in here. And this is a progression in the sense of, greater impingement on the vascular side. Their blood pressure is quite high. They have true dyslipidemias, homocysteine that is probably 15 or above, elevated fibrinogen, HSCRP usually above 3, or at least above 2. Known cardiac risk factors, but also now they're scoring positive on the PHQ-9. We might be beginning to see decline in cognition, an elevated resting heart rate above 76, or decreased measured heart rate variability. We could see an increase in carotid intimal medial thickness on measurement, or positive ABIs, which are ankle brachial index, coronary artery calcium scoring above 50%, ApoE4 allele or MTHFR allele, and then Triad 2 symptoms. So this is Alice Washington. She's our 55-year-old social worker interested in HRT, a history of depression, fatigue, and stress. She feels frayed around the edges. Nerves are raw. She's also expressing some reflux, palpitations, achy joints, and dry skin with a recent diagnosis of hypertension. And so, this is not uncommon for a patient at this age who comes to your practice and she might want some hormone replacement. But when you really listen to her story and you say, well, she's depressed, she's stressed, she's fatigued, she's fraying, she has gut-related issues, so she's implying a gut Triad 2 imbalance, as well as expression of all of that through Triad 3. So you can hear Triad 1, Triad 2, as well as Triad 3 in an Alice, and you need to be mindful of that. So she might think that her mood and energy is all related to a hormonal decline, and it very well may be. But my suggestion is you have to fix the other issues first before you'd even consider hormone replacement in someone like her. And this is where I think the mistakes are made in our industry, where we tend to reach for the hormones, at least some of us do, way too soon. And it could be a real disaster if you don't fix the underlying issues. So she really ends up being probably a Triad 1, a Triad 2, a Triad 3, and a Triad 5, which is estrogen, progesterone, and testosterone. She may very well have low reproductive hormones. And then finally, a true final expression of cardiopulmonary neurovascular. These patients have, real pump dysfunction, dyspnea on exertion, shortness of breath, fatigue. They're burned out. They have edema, cool extremities, palpitations, arrhythmias. So these are the sickest of the sick. And that is also expressed through real cognitive decline and serious depression. So in the same way that gut immune brain can be autoimmunity and cancer and cognitive issues, so too can you have real end organ problems with the heart and brain as well. And what does this look like? In terms of the final measurements of heart health, it's, a lowered ejection fraction, decreased pulmonary function testing, coronary artery calcium scoring, known heart disease or peripheral vascular disease. They, have problems on their stress tests, abnormal EKGs and arrhythmias, and we may see changes in renal function. So elevated creatinine, as well as decreased GFR or liver-related inflammation as they're gaining weight and becoming, hepatorenal on top of, cardiac disease. So these are obviously very, very sick patients, and they have a great potential for, serious illness. So Brian Wallace, he's our cardiopulmonary expression, 67-year-old auto worker with a 60-pack year smoking history. He's a bullish man with large appetites. He desires some anti-aging for his aging body. He noticed fatigue on a recent hunting trip, takes an unexpected trip to the cath lab to stent a widowmaker, which is a thrombus in the left main. So very few people tend to survive that sort of cardiac event. We've talked about the symptom scales. Again, it's a progression from functional to moderate to most disturbed. And here are all of your potential options for correcting the imbalances that we see within Triad 3, and we'll go through these in the context of each of the patients. So Joan Johnson, she's our kinetic ad exec, no significant symptoms, late night smoking, caffeine. Her LDL is 155. Standard now, depending on risk factors, is 100. Still, for some categories, 120. But the idea is that, clearly she's elevated, and you worried that she's oxidizing her LDL because she's a smoker. Her homocysteine is clearly above 6, so 15 is way too high. She has a little bit of urine microalbuminuria at 35. Remember, anything above 30 and up to 300 is significant. She's quite inflamed. You want her below 1. Anything above 3 or at 3 is high risk, so 3 and above is a real problem. Her fibrinogen is also elevated at 430. And then she has an elevated cortisol, so she's under significant stress. She's melting her brain, she's melting her vascular system, she's melting her gut lining, and all of this needs to be corrected because she's getting this sort of metabolic load into her vascular system. And again, she feels fine. This is the silent killer. But when you look at her extended risk factors, she has a real problem. So what do you want to do for her? You want to target her endothelial dysfunction, which means reduce inflammation, oxidative stress, and coagulability, and therefore improve nitric oxide production. You can do things like endopat or other in-office measurement tools if you have the ability to do that, especially if you're billing insurance. But I think if you just stick with the basic risk factors that we can all measure, you'll be well served. You want to manage dyslipidemias, so get her cholesterol down and reduce oxidized LDL or ApoB. Reduce cardiac risk factors, including blood pressure, smoking, and weight. So what do we want to do? You can do a caveman or metabolic code diet, lower carb, low GI to reduce that inflammatory load, decrease that insulin, improve micronutrient status, and make sure that she's not generating any food immune compounds that could be triggering her inflammation. So does she have a small LDL? As I mentioned, the small ones are not so good. They fall into the cracks. If yes, fish oil will increase the size of LDL, but so too will aged garlic extract. And you'll see, I'll keep mentioning aged garlic throughout this talk because so many things resolve with aged garlic. There's extraordinary research coming out of Dr. Budoff's lab on the West Coast. I think he's at UCLA now, looking at the role of aged garlic in cardiovascular disease, reversing progression of plaquing, reversing of ectopic fat, reducing homocysteine. I know you've read about aged garlic, but it really is a very important therapy for these patients. Do they have high LDL? Well, if it's above 110, you could always consider plant sterols. These are plant cholesterols that remove cholesterol from micelles in the gut lining. Study dose is about 2.4 grams per day, really between 2 and 3. Anything above 160, you probably want to choose red yeast rice. Minimum dosing, I would say 600 twice a day, so 1,200. But you can go up to 2,400 or even higher, up to even 4,800 milligrams. There's new data to suggest that statins and probably red yeast rice are even better taken all at night in a single dose because that's when the enzyme HMG-CoA reductase is active as well in the liver. So you can take your total dose of 1,200 to 4,800 in the evening, and I've seen tremendous results. You can also add tocotrienols, which are the derivatives of vitamin E. It's the gamma delta fraction. And there are a number of these on the market that are very good at lowering cholesterol too, aged garlic extract, and niacin if LDL does not decrease. Now, niacin obviously is tried and true. It actually improves clinical outcomes. Some people just don't like the flushing, but it's been well studied. If they're oxidizing their LDL, meaning do they have a low pH or did you measure it directly? Meaning are they a smoker, overweight, stress, or poor diet? Aged garlic will help with an oxidized LDL. In women, specifically pomegranate has been studied. If they've known heart disease, you want to go up to 400 milligrams. You can always add tocotrienols too if known heart disease or peripheral vascular disease. Key concept, check salivary pH. If below 6.8, then you can assume an oxidized LDL. If it's below 6, you want to intervene with alkalinizing therapy such as a green drink or vegetable broth from peels except the nightshades. So you want to raise the alkalinity, and you can have them measure urine pH in the morning and make sure that they're improving it. Do they have a low HDL? There's a few things that raise it. Exercise does, krill oil does, fish oil maybe, but I think krill has actually been shown to be better. And even maybe bergamot. So bergamot has been shown to raise HDL as well. It's a very nice little product that I know I keep mentioning. For triglycerides, remember this is a measure of sugar intake. If anything above 100, you want to reduce carbohydrates, and then certainly extended release niacin, 1500 to 2000. They do need to flush for it to work, but fish oil does it, and fish oil has been shown to be very good at lowering triglycerides. But the main is sugar. So when you look at a cholesterol panel, if triglycerides are elevated, you really just have to fix the diet. Lipoprotein A, this is another cholesterol marker. It's mostly genetically mediated. We know that if it's elevated above 30, there's a risk for heart disease. Niacin is one of the few things that really lowers LPA effectively. I haven't seen a lot of other dietary supplements lower LPA. Lifestyle does to some degree, but again, it's genetically driven. So even that, unfortunately, doesn't create a lot of movement with LPA. If intermediate density or remnant lipoproteins are elevated, you want to seek causative factors such as insulin resistance or low thyroid. So we're into Triad 1 if you see these markers reported on your expanded cholesterol profile. Are they on statins? If yes, you want to add some CoQ10, anywhere from 100 to 300 milligrams, as well as you want to check vitamin D. Remember, the lower the cholesterol, the lower the hormones overall. And so vitamin D is a hormone, so it's been linked with low cholesterol or statin use, but so too has been low testosterone, low DHEA. So you want to consider measuring all of these hormones if they're on a statin. Do they have an elevated high sensitivity CRP? If it's above 2, aged garlic. If it's above 3, add fish oil. If it's above 4, green tea extract or polyphenols, which actually have been shown to lower vascular-related inflammation. And this really gets into the relationship between oxidative stress and inflammation because, of course, green tea extract is an antioxidant, not a direct anti-inflammatory, but it actually has been shown as a result to lower CRP. So if presence of insulin resistance or diabetes, you want to add borage oil, 600 milligrams daily to provide GLA or gamma-linolenic acid due to reduce conversion from omega-6 fatty acids. So diabetics in particular really need some support in this regard. Borage oil or evening primrose oil, all of which is very good, especially when you see patients that are diabetic and they have that dry, shiny skin. It means that they have deficiencies of GLA, and you want to add that in as a healthy fatty acid. Hypercoagulability, if their fibrinogen is at least above 370, if not 430. Aged garlic extract is very good at reducing fibrinogen. Pleomuc, which is a homeopathic remedy, 4 drops under the tongue. And then nattokinase. Nattokinase is a natural enzyme, which has been shown to also reduce fibrinogen. There is some data to suggest that if you have a patient with arrhythmias, especially AFib, and they do not want to do a typical blood thinner, nattokinase is an option. The brand name is called Cardiokinase. I've not gotten up the courage to use cardiokinase exclusively in these patients with AFib, but it is an option, especially if they insist on not using a normal anticoagulant if they have an arrhythmia. So there are some options, and I know there's some Japanese literature to suggest that nattokinase, which comes from natto, it's a traditional foodstuff out of Asia, is effective. But for legal reasons, quite frankly, I'm not so sure I would recommend it alone. But I do have patients that insist, and even though I can document and say I advise them to use one of the standard anticoagulants, they're pretty savvy and they know that they want to try some cardiokinase. For hypertension, initially you want to screen them for heavy metals, insulin resistance, and stress. So Triad 1 and Triad 4. Theanine, green tea extract, we've talked about this for stress, actually lowers blood pressure. Magnesium taurate, the taurate salt is much better for heart-related issues than any other magnesium form. Taurine in particular is very calming to the cardiovascular system. So we like magnesium taurate to bowel tolerance. You want to advise weight loss as you're detoxifying them and improving their stress response and insulin. If they're above 130/80, again, you can add in that arginine. It's 1,000 milligram capsules, 3 caps twice a day. Consider adding that aged garlic because that's been shown to lower blood pressure. You can also add hawthorn, 450 milligrams twice a day. It's been shown to lower blood pressure as well as improve heart function. And then even milk peptides. These are protein extracts which kind of work like ACE inhibitors, 500 milligrams twice a day. And then finally, if they're frankly hypertensive, we add in an ACE inhibitor like a lisinopril. This has now really become first-line therapy. It used to be hydrochlorothiazide. If they have microalbuminuria, anywhere between 20 and 200. If yes, grapeseed extract and horse chestnut. So why am I doing that? Because their vessels have become leaky and we're seeing protein spilling in the urine. Sometimes you want to do it anyway, like a horse chestnut seed extract. You can always add quercetin in 60 days if you're not lowering their blood pressure effectively. And sometimes that antihistamine actually helps in terms of the quercetin. Key concept, check MTHFR. And you want to add in some methylfolate, anywhere, I think, between 1 and 6 milligrams of methylfolate. So once again, Joan Johnson, she's our kinetic ad exec, no significant symptoms, late nights and smoking. Her LDL is elevated, her homocysteine is elevated, her microalbumin is somewhat elevated, so her CRP and fibrinogen as well as cortisol. So she's leaky, she's inflamed, she has additional risk accruing within her vascular system. So what do you want to do for her? You want to correct her endothelial dysfunction. You probably want to start with aged garlic extract, horse chestnut seed, and methyl tetrahydrofolate because of her elevated homocysteine, her blood pressure issues, as well as her LDL. With her lipids, consider adding her sterols and pomegranate. Remember, pomegranate is particularly good for women. And then deal with her risk factors. Check heavy metals, quit smoking, and then her stress with magnolia phellodendron, breathing techniques, contemplative practices, Tai Chi, Qigong, so on and so forth. This is our next patient. This is Alice Washington. She's our 55-year-old social worker. Depression, stress, and fatigue. She's feeling frayed around the edges. She has reflux, palpitations, and achy joints, as well as being hypertensive. She's frankly hypertensive at 160/90. She has an elevated LDL, higher urine microalbumin than Joan, higher CRP than Joan, and a flattened cortisol curve, so she's liberated her immune system, and a relatively high fasting insulin at 35. Remember, 22 or above is hyperinsulinemia. So she's really in trouble. But she's also scoring positive on her PHQ-9, so she's showing elements of depression. Her memory is intact at 27. 27 or above is normal. Her resting heart rate is elevated at 79, so she's stressed, which makes sense because she's flattened her curve. She has a SNP on her ApoE4, and her white blood cell diff is 13, so she's got inflammation on her gut lining, meaning that she's triggering food sensitivities. So she is a Triad 1, Triad 2, and Triad 3 all together. Now remember, she wanted to come in for hormone balancing. I don't think you'd want to do hormone balancing in her. I think you'd really want to work on her diet, modulate the stress response, reverse that blood sugar issue, really go after the gut, maybe check a food panel, reduce her inflammation, bring her back and see what her blood pressure and her cholesterol is doing just on Triad 1 and Triad 2 interventions. If she's still somewhat hypertensive, or hyperlipidemic, you may want to do something. And maybe even in her case, you want to start a blood pressure med. But just look at this patient. She comes in for one thing, and it's a chance to do deeper work with her. So what do you want to do? You want to target her vascular pathology, including Triad 1. You want to closely monitor her depression, including Triad 2. And you want to modify her risk factors, such as blood pressure, and be vigilant for cognitive decline because she's clearly at risk for that, for all that neuroinflammation. So dietary considerations, that metabolic code diet, lower carb, low GI. Make sure that you decrease inflammation through a healthier food program. You certainly could apply the DASH diet, DASH 1, DASH 2. We think the metabolic code diet is even better in this situation. What do you want to do for her hypertension? Quite frankly, she would qualify for lisinopril in addition to moving through looking at heavy metals. She clearly has insulin issues and stress problems. She certainly would need at least theanine, refill the tank with magnesium, and try and gain control through some dietary supplements as well as the lisinopril as you're correcting the underlying issues. Her dyslipidemias are pretty obvious because she has a very high LDL. I'd probably start her actually on red yeast rice. I may not even reach for the sterols. Now remember, she is 165, so I'd do a higher dose. I'd do more than 1,200 at night. I might do 2,400 or even 3,600. She does have microalbuminuria, and so she needs to be on some grapeseed extract and horse chestnut seed, which is actually good for her vascular lining too, because they're polyphenols, antioxidants. She is very inflamed, so you will want to do aged garlic, probably some form of fish oil, and green tea extract. She's positive on her PHQ-9. You could consider doing either St. John's wort, but you do get drug interaction or drug herb interactions as well as herb interactions with St. John's wort. You could also consider SAM-E. The standard way of doing SAM-E is a loading dose. It's 800 milligrams twice a day for a week, then 400 milligrams twice a day for a week, and then 400 to 800 milligrams daily thereafter, in addition to recharging the methylation cycle with B6, B12, and folate. Does she have a flattened cortisol pattern? If yes, but no reflexes, you want to do adrenal glandulars and adaptogens. If yes, you want to add in some alpha GPC, which is glycerophosphocholene, which will stimulate her peripheral nervous system. So she's gotten pretty depleted on her acetylcholine side. And this will also help with her memory too. So alpha GPC in particular has been studied in cognitive decline. So, if she's fried her brain and she's really expressing that through slow reflexes, you want to help her memory, and that can be through alpha GPC. Is there evidence of true mild cognitive impairment, a change on her minimum mental status exam of at least 4? You can add in some huperzine, alpha GPC, and acetyl L-carnitine. These come as combination agents, 1 cap 2 to 3 times a day. Is there evidence of autoimmunity? You can also add in some RG3. This is sublingual 5 milligram tabs 2 to 3 daily. Or you can do the nasal spray at 2 milligrams with nicotinamide riboside. Those are 2 milligrams apiece. And that comes from specialty compounding in Texas with Ray Solano. Do they have an elevated resting heart rate? If it's above 76, you could do phenyl-GABA. So GABA is very calming to the nervous system. Do they have additional difficulty sleeping or GI complaints? Remember, holy basil is particularly good for stress and IBS. And certainly because of the blood pressure, you could add in some theanine. So you have some choices here with regard to the stress that she's under, but you really need to get that resting heart rate down through exercise, deep breathing techniques, adequate stress, and sleep. If presence of peripheral vascular disease, intermittent claudication, depression, and elevated homocysteine, you want to start ginkgo, 100 to 240 milligrams daily, but avoid if they're on Coumadin. Heavy metals, insulin resistance, and hypothyroid, if yes, alpha-lipoic acid, 600 milligrams twice a day. If no, aged garlic, because aged garlic is very good at removing heavy metals as well as improving thyroid function. Known cerebrovascular event, if yes, Cistantia. I know you've reviewed that in your monographs. Very good herb out of China, 1,000 milligrams twice a day. Alpha GPC, I've already mentioned for memory and protecting the brain. Cerebrum compositum, which is a homeopathic remedy, 1 tab chewed 3 times a day. Green tea extract, 250 milligrams twice a day. Resveratrol, 200 milligrams 2 to 3 times a day. And then even vinpocetine, which has been shown to help prevent further progression cerebrovascular accidents. And then, so this is a reminder. She's our 55-year-old social worker. Her blood pressure was elevated. Her LDL was elevated. Her urine microalbumin was elevated, CRP as well, so on and so forth. So what are we going to do for her? I would add in red yeast rice, aged garlic extract, fish oil, horse chestnut seed, and lisinopril to gain control of her blood pressure, reduce vascular inflammation and oxidative stress. You also have to protect her brain because of her measured issues as well as symptoms. MTHF, so methyl tetrahydrofolate, SAM-E, alpha GPC, phenyl-GABA, and alpha-lipoic acid. And then finally, risk factors, check for metals and serial PHQ-9 and MMSE. So you really have to fix Triad 1, Triad 2, as well as give her direct support for Triad 3. And this is how I would do it with her. And then finally, Brian Wallace. He's the 67-year-old hunter with the 60-pack year history of smoking. He had the Widowmaker with the left main thrombus. which sent him to the cath lab. He actually survived. This is a real patient of mine. He does come riding up on a Harley with, a cigarette stuck in his mouth, and refuses to wear anything other than the most minimal helmet. He's a very big guy. His BMI is over 40, and he's big in stature, big in personality. And you could see that, not only does he have a lowered ejection fraction of 34%, and he has the COPD from smoking, known heart disease. He's got PVCs on EKG, but he's got renal impairment as well. And so his mood is okay, but he has cognitive decline, so his memory is not that great. And he has to bring his wife to a lot of his clinic meetings with me because he just can't remember things that I say, and he's very frustrated by that. His resting heart rate is significantly elevated at 81, so even not measuring heart rate variability, that he's under a lot of metabolic stress. He's very depleted. Not surprisingly, his magnesium is quite low at 1.2. You want this to be at least 5.0 or above. His LDL is quite high at 200. His fibrinogen is very, very high at 540, so his blood is quite sticky. He's incredibly inflamed at 9.3, and he's very insulin resistant. So he is a fully expressed Triad 1, Triad 3. So target vascular pathology, monitor cognitive dysfunction or function, and then address pump-related issues, meaning heart. So you got to clean up his diet. I mean, that's number 1, 2, and 3 on the list. And for me, I've been working with his wife. We have them connected with our health coach. They're on the portal. They're getting healthy recipes, and we're monitoring very closely his weights. Known heart disease, vitamin K2, which shuttles calcium away from the vascular tree and down into the bones where it needs to go. Most of the products on the market are 45 micrograms twice a day. And you want the menaquinones. This is vitamin K2. It's version 7. Grapeseed extract, 300 twice a day to shore up those vessels. Aged garlic, at least 1,200 twice a day. Vitamin C buffer, 2,000 to 5,000 milligrams for antioxidant status, and then quercetin for leaky blood vessels. And then check for metals too. So this is a guy who's really compromised, and he's loading completely into his vascular system, and you need to do a lot to protect him. For heart failure, is it class 1? Replete minerals, carnitine, CoQ10, and ribose. These are the big 3 for improving ATP output and heart function. Carnitine's 1,000 twice a day, CoQ10 150 milligrams at least, up to 750 milligrams, and then ribose 5 grams 3 times a day. If they're class 2 to 3, add in some hawthorn 3 times a day. And then finally, class 4, you want to check for viruses, make sure that you're not missing any vectors or toxins, essentially. For arrhythmias, fish oil, 1 to 2 grams daily, which has been shown particularly to be effective post-MI within the first several months. Is there muscle cramping? Again, mag taurate, lots and lots of mag taurate, essentially at bowel tolerance. If there are breakthrough arrhythmias, hawthorn actually has been shown to have some antiarrhythmic properties as well. Are there thrombus risk? Aged garlic is very good, but if they have easy bruising, meaning that you're trying to give them anticoagulation, but they have leaky vessels, add some quercetin. If it's bruising, it's quercetin. If it's petechiae, bilberry is quite good for that. So remember, he's got problems in every direction, and you're really going to have to work very hard to treat all 3 corners of the triad effectively, in addition to addressing Triad 1 and Triad 2. So what would you do for him? For her vascular system, red yeast rice, vitamin K2, aged garlic, C, quercetin, check for metals. For the neuro, because of his declining memory, the huperzine, GPC, and the acetyl L-carnitine, as well as L-theanine and alpha-lipoic acid. And then finally, for pump function, carnitine, CoQ10, ribose, arrhythmias, hawthorn, as well as pump function class 2 and 3, mag taurate, and fish oil. So this is a guy who obviously is very, very sick, and a lot needs to happen with him. Diet, exercise, stress management, all of the Triad 1 stuff, as well as gaining control of Triad 2, because if he's so inflamed, he's likely got some food sensitivities that need to be cleaned up as well. But you can fix a guy like this. The other thing, which I didn't really talk about, which we will in Triad 4, is IV EDTA. So if you have the setup for it, and you look at the results of the TAC trial, especially for patients that are both diabetic and have heart disease. Removing lead and cadmium by IV EDTA could be very helpful for him, and I certainly would do that in my practice. So, this is a treatment of, I think, a really important triad, and you can see how the stacking is beginning to take shape. And the primary ones are 1, 2, and 3, and then you'll see as we get into Triad 4 with the drainage organs, toxins tend to overlay on all first 3 triads, and then the final one, which is estrogen, progesterone, testosterone, hormonal balance, also tends to overlay across all of them as well. So we've gotten through finally 1, 2, and 3, and you're beginning to see, I think, how these things begin to take shape and intersect. This week and next are very much focused on, how do I begin to organize my treatment plans with respect to blood pressure, lipid abnormalities, and general cardiovascular and cognitive issues. So try and find patients for your cases that focus on those areas. Sometimes they just have to have known related problems with blood pressure or cholesterol, for example, as you're developing cases. But remember, 1 and 2 create vector forces on Triad 3 in a sense. So, it's fine if you have a mix of 1, 2, and 3 for these cases, and that's real life. That's how this really goes. So if you have any questions, certainly email me through the Blackboard system, and have a good rest of the week.